All disease. The best way to change people's lives. This is why we believe in what science can do.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do. Fueled by imagination, alone and with others. This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do. Fueled by imagination, alone and with others. This is for scientists.
Zeneca every day starts with this challenge, to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen. We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way. That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
Alone and with others. Repeating an experiment 1,000 times to have the chance. And those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown. Fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do. Fueled by imagination.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics,
areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen. We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way. That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. Boundaries of that science and making bold choices so that we can deliver life-changing medicines.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
At AstraZeneca, every day starts with this means challenge. Making choices based on what the science is telling us. To be curious and challenge conventional thinking and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities. Medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage.
Diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab, or in an office, or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Our success depends on the unique combination of scientific capabilities in small molecules.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare
Our
professionals,
medicines are used
all
by
of us are
millions
striving
of
every
people
day
worldwide.
to push the
And it takes
boundaries
the
of that
efforts of more than
science and making bold
50,000
choices
employees
so
in
that
more than
we
100
can deliver
countries to make that
life-changing
happen.
medicines.
We want to be valued for great medicines,
Because we believe
but we
in
also
what
want to be
science can do.
trusted.
Fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices.
As a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown. Fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
Life-changing medicines. This means making choices based on what the science is.
This is for scientists
and challenge conventional thinking.
and those who believe in the potential of science.
Needed to achieve breakthroughs.
It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown. Fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
Cancer types. It's a non-invasive blood test.
Our medicines are used by millions.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. Starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do.
Push the boundaries of science to deliver life-changing medicines. At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted.
Because putting science at the center of everything is the best way to understand and transform disease.
Boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also
Pieces
want
of
to be
DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab, or in an office, or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab, or in an office, or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others. Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science.
Joining us for this afternoon's Ghana Gynae Summit. This is the second edition that we are holding from AstraZeneca. Last year, we held the maiden edition, and it was very exciting. So thank you once again, especially for our participants online who have had to keep their patience, and also for our in-house participants as well. We start shortly, and then we'll have our speakers take the podium and then share with us key insights in relation to our agenda today. My name is Edward. I'm with the AstraZeneca team, and I'll be part of the vocation whilst I help, our speakers also, in terms of when there's a Q&A session, guide and also assist you with anything that you need whilst you're here. For our in-house participants, I will entreat you that we have snacks served at the back of the podium. So just in case, you want to, take snacks, you can just go directly to the table and just pick something and just come back to your table. So just bear with us and we'll start shortly. Thank you very much.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing
Hear me now?
medicines.
Oh, I hear myself. Hello?
Because we believe
Hello?
what science
Can you
can
hear
do.
me? Okay. I think the MC just spoke about snacks, but I haven't seen anybody get up yet. I think the only benefit you get from coming early is having your snacks earlier, so that the ones who are late, by the time they come, the food is finished. When they come and it's finished, next time they'll come early, so you are not penalized for being here that long. I want to take the opportunity to tell you just a little bit about FESOC. My name is Ifu. I'm with the FESOC team. Are there any FESOC members here, apart from the panelists who will be speaking? Hi, Team FESOC. Only two? Wow. Wow. I see you. I see Dr. Gordon as well. Okay. Please, do you know about the Fertility Society of Ghana? If you know anything at all about us, can I see by a show of hands? Dr. Agbevadi. Okay. All right. So let me tell you a little bit about FESOC. Fertility Society of Ghana is the full name for the acronym. It was birthed in 2016 and has a group of 9 executives. The president is Dr. Edem Hiaji. The vice president is Dr. Richard Banfo. The general secretary is Dr. Rudolph Adagaba. The assistant general secretary is embryologist Ellis Fletcher Juleto. As part of our council, we have Professor Yao Kwaukume. We also have Dr. Kofi Ameni Ampong, and we have Dr. Owusuba, Dr. Paul Owusuba from Tema Women's Hospital as well as part of our council. So under their leadership so far, the society has been able to hold, every year we've held an AGM, some of which has been with some international organizations such as the IFFS, and we have partner organizations like the AFFS, that's the African Federation of Fertility Societies, and the IFFS is the International Federation of Fertility Societies, of which we are part. So this group has the mission of harnessing the role of all stakeholders in assisted conception. And if we say all stakeholders, we mean all. It doesn't matter whether you are a pharmacist or a lab technologist, whichever part of the medical field you come from. If you are interested in part of assisted reproduction, yes, we are interested in your membership, and you will be interested in joining us as well. What I would ask is that if you want any further information or you'd like to come and become a member of FESOG, you will just have to send an email to the Fertility Society of Ghana at gmail.com, and we would send you the information on membership form, and any other information that you need, and you can become a member. We are a very vibrant group of people who are interested in anything fertility. We are currently working on regulation in the space for assisted conception. I know a lot of you agree with me, especially the OBGYNs here and the reproductive and endocrinologists, that there are lots of centers that are coming up that are, you have labels on it that say fertility center or fertility hospital, or they are doing fertility. There are so many springing up every day. But if you're on the side of a patient, or you have a, let's say, a relative who has a fertility issue, okay, whether it's a man or a woman, which one would you recommend for them? Do you know any information about them? Who is in charge of it? There are so many questions that you'll be asking. Sometimes you're not sure. So under the umbrella of the Fertility Society of Ghana, we have a lot of clinics and hospitals that we have registered with us, that we can have some level of inputs in their operations, so that when you go there, you know that at least you are getting people who are have an eye on them, so are forced or are have to adhere to a high standard of provision of care. So that is why the Fertility Society of Ghana is there. We are not yet, I won't say we are a police, but we are a convener for the fertility space. So I would encourage, as I can see that 90% of the people here are not part of the society. As we are here at the Gynae Summit with AstraZeneca, I would encourage you when we are done to get in touch with the society. If you know any of our council members, I'll be around for the whole time that we are here. You can approach me. If you don't want to approach me, I will approach you. You can be sure of that. I'm not shy of anything. I will come and then we'll talk about membership. So I will make up for your shyness if you are shy. I'm very happy that most people are eating. I think my voice is very soothing, so it's making people hungry to want to take their snack. So thank you very much for listening to me. My name is Ifwadazi, and thank you so much. I know the weather is a bit dreamy. I'm feeling sleepy myself. But I know that once the session starts, our speakers are very interesting, very expert, very professional in their field, I can assure you. So you're going to have a lot of knowledge that is shared today. So thank you so much for coming. I know there are more people on their way, so we'll wait for them to come. Our chairman will be here soon as well. Thank you so much. Take care.
Shall we give a round of applause, please? Thank you so much. Okay, so we'll use this opportunity to also still indulge our online participants that please bear with us. We know we are far behind time and we are just counting on our chairman to start the occasion. So kindly bear with us the next 5 minutes. We should start the summit and then we start our presentation shortly so that we can get the full benefits of all the wonderful scientific evidence that our speakers will share with us today. So just bear with us. Thank you very much.
Repeating an experiment 1,000 times to have the chance to get it right. Once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science. In everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease. The best way to change people's lives. This is why we believe in what science can do. This is for scientists and those who believe in the potential of science. It starts with curiosity.
At AstraZeneca, every day starts with this
surprise
challenge
in the pattern.
to push the boundaries of science to deliver life-changing medicines.
Step by step by step, they challenge, explore,
This
and
means
unlock
making
the unknown.
choices based on what the science
Fueled
is telling
by
us.
imagination.
Be curious and challenge conventional
Alone and
thinking
with others.
and making the bold choices on the science
Repeating an
needed to achieve
experiment 1,000
breakthroughs.
times to have the chance to get
Our
it right.
success depends on the unique
Once,
combination of
but for
scientific
forever.
capabilities in small
Making
molecules,
brave
biologics,
choices.
immunotherapies,
Choosing to
protein
push the
engineering
boundaries.
technologies,
And choosing
oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or in an office or out meeting healthcare professionals, all of us are striving every day to push the boundaries of that science and making bold choices so that we can deliver life-changing medicines. Because we believe in what science can do.
This is for scientists and those who believe in the potential of science. It starts with curiosity, a surprise in the pattern, an obstacle that can't be explained. Step by step by step, they challenge, explore, and unlock the unknown, fueled by imagination, alone and with others, repeating an experiment 1,000 times to have the chance to get it right, once, but for forever. Making brave choices, choosing to push the boundaries, and choosing again and again to be led by science in everyday decisions, everyday interactions, no matter where they are. Because putting science at the center of everything is the best way to understand and transform disease, the best way to change people's lives. This is why we believe in what science can do.
At AstraZeneca, every day starts with this challenge: to push the boundaries of science to deliver life-changing medicines. This means making choices based on what the science is telling us, to be curious and challenge conventional thinking, and making the bold choices on the science needed to achieve breakthroughs.
Our success depends on the unique combination of scientific capabilities in small molecules, biologics, immunotherapies, protein engineering technologies, oligonucleotides, and medical devices. We combine that with a strong focus on translational science and personalized healthcare. And we know the best science doesn't happen in isolation. It happens through collaboration.
Every day we go to work knowing the diseases we work on are complex and difficult to treat.
Cancer is one example. With cancer medicines, we're proud to be building on 40 years of heritage. But today, we're focusing on new areas of science, such as harnessing the body's own immune system to fight tumors.
Another is diagnostic testing for people with cancer. Pieces of DNA break off from a tumor, and we can now detect these in certain cancer types. It's a non-invasive blood test.
Our medicines are used by millions of people worldwide, and it takes the efforts of more than 50,000 employees in more than 100 countries to make that happen.
We want to be valued for great medicines, but we also want to be trusted as a company that delivers them in a sustainable way.
That's why our focus is on access to healthcare and environmental sustainability.
You want to believe when you come to work every day that you can make a difference. For us, it starts with the science. And whether you work in the lab or
little mishaps and late starts, we are far behind time. My name is Sharon Kukwa Gaitwa, and I work with AstraZeneca. I handle the oncology and benign gynecological conditions for AstraZeneca, the portfolio. So I welcome you all to today's second edition of Ghana Gynae Summit. This is an initiative, of AstraZeneca. We started last year, and we saw that it was very helpful. It was very insightful. So we decided to do another edition. So we have very interesting speakers. They are well informed in the area where they will be speaking on. So unfortunately, our chairman is running a bit late, but he will join us. So I'll introduce the chairman, and when he joins us, he'll give his response. Yes. So this person is a consultant, obs and gynae specialist, and fertility specialist. He is a retired assistant commissioner of police and the Ghana Police Service, and he's also the CEO of Lister Hospital, and he's well known for fertility, well known for obs and gynae disease areas, and he's in the person of Dr. Edem Kojo Hiaji. So we can give him a round of applause whilst we wait as he comes. So once we are far behind time, I want us to start with our first speaker. So our first speaker, in fact, he has a lot of credentials, and it's so much for me. So I'll just invite him to come. He's in the person of Dr. Michael Yao Intumi.
Thank you. So it's not projected. Thank you very much, Sharon. And I think it's still afternoon, so good afternoon, everyone. Again, thank you, AstraZeneca, and then FESOC for the privilege to be able to present this at the second meeting of Ghana Gynae Summit. So my topic is basically on the use of GnRH in fibroids. But so that we can situate it clearly in the context of medical management, I labeled this as medical management of uterine fibroids and the role of GnRH analogs. So that is what we will do. That's okay. So that is a disclaimer. So this is what I want to use to achieve my aim of introducing us or telling us about medical issues or medical management of uterine fibroids and the role of GnRH analogs. So we'll talk a bit about introduction, clinical features, options for medical management, and then we'll talk a bit more detail about Zoladex or GnRH analogs, and then we'll conclude, and then we'll wait for discussions. So by way of introduction, fibroids are very common. In fact, our people like to call it fabulous because it's so common that they have all kinds of names for it. Now, we know that these are monoclonal tumors that are benign, but even though they are benign, they cause a lot of harm, a lot of anxiety, and worry a lot of our women. Now, the challenge is that these tumors are common in the reproductive years when the uterus is supposed to be incubating a fetus, is rather growing fibroids. Now, the incidence of uterine fibroids, or even more specifically the prevalence of uterine fibroids, is very difficult to diagnose because the disease increases, the incidence increases with age, and then because most people are not symptomatic, it becomes very difficult to tell how many people specifically have the disease. Now, in some areas, in some countries, for instance, the statistics I put there is in the US. That's the most recent data. 2003 data says that cumulatively for women who are above 50 years, as high as 70 to 80% of them would have fibroids. And the distribution is about 80% for women of African descent and 70% for the Caucasian population. So clearly, it is much more commoner in women of African descent. Exact prevalence data for Ghana has been difficult to get. However, thankfully, just a few weeks ago, Ezi et al., published this from Cape Coast Teaching Hospital, says that, they were not looking at the prevalence, they were looking at the annual incidence of this condition. And they found out that from 2018 right to 2022, the annual incident rate was 66 all the way to 92.4 per 100,000 women. What is clear here is that the prevalence of incident is increasing as the years go by. And the age of first diagnosis is also decreasing. In that paper, they discovered that the age of first diagnosis is about 34 years compared to 43 in the European population. Now, fibroids grow in response to estrogens. And then in addition to that, they have what we call growth factor they statistically work with. In the past, it was thought that fibroids grow only in response to estrogen. But now we know that both major hormones, progesterone and estrogens, are equally involved. What happens is that during the proliferatory phase, estrogen would enhance the development of receptors of both estrogen and progesterone receptors. And then in the luteal phase, it enhances progesterone to cause mitogenesis, so the increase in the proliferation of the fibroids to cause the problem. And then, like I said earlier, they add together with growth factors to be able to cause the problem. What it means is that this knowledge creates space for us to be able to target the management. That is where GNRH, for instance, analogs will come in, because we know that if we target them, then we can target the growth of these tumors. Okay. Now, just a slide on impact on society. Most of us here, I can see my teachers here, and my teachers are all here, have recognized the impact that fibroid plays in relationships. Some people leave their girlfriends because you were told that they had fibroids and not give it again. And that would disrupt an otherwise healthy relationship. When it comes to employment, I don't know how many of us haven't been writing excuse duty for these women because they bled excessively. And then economically, yes, it's always a problem. Now, but more importantly, we talk about bleeding and all that, but what about the impact on the quality of life of these women? The evidence clearly showed from the slide here that when you examine the quality of life of these women, their quality of life is lower, or at best comparable to women who have chronic diseases like chronic hypertension, diabetes, osteoarthritis, and all that. So that's how important it is. And when it comes to the cost, and this data is from the US, as much as $34 billion are spent annually just treating fibroids. And for individual patients, about $4,600 is used. I think most of us gynecologists here can estimate averagely how much our patients pay or how much they spend to get fibroid adequately treated. Okay, so this is just a slide on the presentations. We can group them into 4 major groups: abnormal uterine bleeding and the bulk symptoms. Either it is so huge it disfigures the woman, or it's compressing the bladder or the rectum, causing problems. Then pain. I've had one before and it was terrible. A patient, not myself, I don't have fibroids, but my patient has severe back pain. Okay, and it was so bad, she can't even drive. She had to stop after every 30 minutes. That's how bad it can be. But more importantly, reproductive function can be affected. And that is where FESOC and all the gynecologists here come in, because a lot of our women have fibroids and they want to conceive and they have symptomatic. So what do we do for them? So what about the bleeding? Well, how do they bleed? What causes the bleeding? Well, the exact mechanism is not known. There are a lot of theories, increased surface area and all that. But what we know is that a lot of factors, including microscopic and macroscopic things, come into play there. So yes, there's a distortion of the endometrium, but it appears also that when you have the location rather than the size appears to be the most important, and Figo type 0, 1, and 2. I'll show the picture for that for those of us who are not conversant with the Figo classification of uterine fibroids. We'll see it in the next slide. Okay, so we know also that intramural fibroids, even though they are not usually classified as causing abnormal uterine bleeding, if it's multiple and huge and distort endometrium, yes, it can cause that. But subcervical fibroids are not known to. So this is the figure. So we can see type 0. Where are you? Okay, we can see 0 there. 0 is intracavitary pedunculated. Type 1 is submucosa with more than 50% of the projecting into the uterine cavity. And then type 2 is also submucosa, but more than 50% of them in the myometrium. But these three will certainly cause abnormal uterine bleeding. All right, so I think a bit I talked about the mechanism already. Now, let's talk about treatment, since we are all yearning for the Zoladex and how it works. Now, to treat, we need to do pre-assessment and be sure that the symptoms they come with are not due to something else, but rather in actually the uterine fibroids. So the basic history, physical exam is very, very important. But as of necessity, we need to evaluate these women with the best imaging modality available for uterine fibroids, which is the ultrasound scan. Yes, we want to do an MRI if you want to differentiate the fibroids from adenomyoma, but otherwise, just transvaginal scan is important. If the uterus is more than 12 weeks high, and I'm sure that most of our patients have more than 12 weeks high uterus, then you need to combine with the transvaginal with the abdominal root to be able to assess them properly. Be sure that there's no submucous fibroids, and so you need to assess the endometrium carefully, either using hysteroscopy or saline infusing sonohysterogram. Again, emphasis again on evaluating endometrium, but more importantly, we don't want patients who have myomectomy only to come down a year later with advanced endometrial CA. So must we routinely evaluate the endometrial cavity? Probably not. The recommendation is that if the woman is more than 45 with abnormal uterine bleeding, you need to sample endometrium for histological assessment. For those between 40 and 45, if you suspect that there's something else behind the fibroids, then you can do that. How do you suspect? If you do your assessment, hysteroscopic assessment, and you don't see any submucous fibroid to account for the bleeding, or the woman has a very strong family history of malignancies, then you probably want to do endometrial biopsy to be sure that this man hasn't got anything hiding in there. So now we are getting close to the management. So these are all the options available for managing these patients. On the left, you have the medical management options available to us. But basically, this is what we have currently as medical options available for managing uterine fibroids. Again, like I said from the beginning, because we want to talk about urinary analog, we want to situate it in the context of the other treatment modalities available to us. So I mentioned about 2 or 3 slides on some commonly used treatment options, and then we can focus on concentrate on uterine fibroids. Okay. Now, just to mention that ulipristal acetate was promising as a sperm, that's selective progesterone receptor modulator, was promising and actually launched initially for use in Canada and a few other countries. But there's risk now of some hepatic disorders, and so there's a temporary hold on that. Otherwise, it was going to be helpful. So for the medical management, what are our options? What is the aim? It's not a definitive treatment, certainly. We want to use it as a temporary relief of symptoms for women who are edging close to menopause, because we know that in the menopausal years, fibroid will stop growing. Then also, we want to use for patients who are not suitable for surgery. And I think during the discussion session, we'll give practical examples of some of these conditions. I don't have them on the slide, but we can talk about them during the Q&A session. Then, for most of us, we'll use this as a preoperative agent to decrease the size of stop bleeding, prepare the patient adequately for our surgery. And then, of course, in research programs, when we are testing new drugs, like it happened with the antagonists, until now they are in clinical practice. Okay, so again, just this statement. Before we start a treatment, let's make sure there's nothing hiding in the endometrium. It's very, very important to exclude things in the endometrium. So most of us here use the ECPs, the the estrogen containing contraceptive pills. The thing is that data supporting its use in uterine fibroid is limited. However, nobody will stop you from using it. Why? Because it is cheap and has other benefits. So you can use it as long as it works for you, it's fine. But remember that the data supporting its use in abnormal uterine bleeding for uterine fibroids is very limited. Okay, and it comes in different forms. Most of us are familiar with the oral pills, but it can come in transdermal forms and vaginal rings as well. Again, tranexamic acid, commonly used. Okay, it's an antifibrinolytic agent. It's been said that it can decrease more than blood loss by more than 50% if you use the right dose. Most people do not use the right dose, but if you use the right dose, yes, you may get that reduction in blood volume. And remember that the data, again, just as in fibroids, and its use for abnormal bleeding for fibroid is not yet, there are no RCTs, randomized controlled trials, that validate its use. It's used in menorrhagia from other causes, but fibroid, there's no data that support its use. So we should be careful about that, but you can use it if you want to. Okay. Now, some small study found that there's some necrosis of fibroids when used, but it's just a small study that we cannot put a lot of hopes on that. Okay. Now, the last slide before you go to the Zolades and the group is progestins. Progestins have been abused. And that's why I didn't bring the oral or the injectable progestins, where people come bleeding before you even take a history. Let's give them double Provera. So I decided not to bring that. But the levonorgestrel IUS is very useful for abnormal bleeding. However, again, no large randomized trials exist for its use in fibroids. However, there are smaller observational studies that have proven that it's very useful. So because of that, it's been used. What happens, however, is that for most patients, if the uterus is more than 12 week size, as to happen to most of our women, there's a high expulsion rate. But worthy of note is that in women who expelled it, they still want to have that levonorgestrel IUS inserted because of reduction in blood volume. Okay, so our main focus. So the GnRH agonist. Now, I intentionally chose to put agonists instead of analogs because some people are beginning to classify even antagonists as analogs now. So it becomes a little confusing. So I decided to just put agonists there for us to be clear that we mean the agonists and not antagonists, because antagonists are also in use now in managing uterine fibroids, as we saw in the earlier slides. Now, so the natural GnRH is a decapeptide produced from the hypothalamus, released in a very pulsatile fashion for a very short amplitude. It acts for a few minutes, and then that's it. Now, the analogs, the agonists, are synthetic, structurally similar, so they bind to the same receptors. But unlike the natural one that bind for short periods and then get degraded, this one will bind persistently and cause initial activation to cause an increase in the production of the gonadotrophins and the reproductive hormones, estradiol and progestogen. And then there's a sustained decrease in the gonadotrophins, leading to what people tend to call the pseudomenopause state. It is this hypoestrogenic state that affects most of the benefits or the treatments of GnRH analogs in uterine fibroids. Now, in 2006, a group of investigators led by Chia published a study in 2006. And what they sought to do was to look at the vascular patterns of uterine fibroids and the effect of GnRH analogs on them. Remember, we mentioned that the abnormal bleeding pattern could be due to some of this vascular angiogenesis and abnormal bleeding patterns. So they found out that for women before treatment, when they took their arterioles, their vessels are large with quite intimal hyperplasia. And so they were explaining that this could explain why some of the women bleed heavily. But when they took the same vessels from myoma that were treated with GNRH analogs, they found out there's extensive vasoconstriction and also significant atherosclerosis, so decreasing the blood flow to that vessel. So it means that this analog, this antagonist, would certainly decrease blood loss. And once they cut off blood supply to the fibroid as well, there's going to be a decrease in size of this myoma. Now, they also noticed that some of the fibroid masses actually have receptors, direct receptors to the gonadotrophin releasing hormone. And so this gene analog binds to it, and then they cause suppression of cell proliferation. And then obviously leading to decrease in cell mass and then decrease in the size. Some of them will induce apoptosis. And if you remember medical school, programmed cell death is apoptosis. So some of the cells will die naturally. There is significant decrease in estrogen receptor and progesterone receptor content of these fibroid nodules, leading to a decrease in the volume. Now, several other studies. Now, what you observe from a lot of the references I put there are that these are old references. So I remember when we were in medical school, I'm a little old now, but when we were in medical school, we were told that these were new. And people are still saying these are new. It's not new. Most of the studies were done in the 80s. Okay? So a lot of studies were done to clearly prove that GnRH agonists are very effective in managing uterine fibroids. The first guy who published a study on this was Filicori et al. It's an Italian, and published in 1983. That clearly showed that GnRH agonists cause sustained hypoestrogenic state, okay, and with much significant suppression of the pituitary, anterior pituitary. And followed that, other people then decide to use the agent to see whether they can control uterine fibroids. So the previous slide we talked about Chai et al. In that study, they had a component where they use ultrasound scan to look at the uterine size and volumes after the treatment. And they demonstrated that there's significant decrease in both the uterine volume and the fibroid volume, okay, within 2 months of treatment with GnRH agonists. When you give the depot, the subcut depot at 4 weeks apart, just 2 doses was enough to cause significant decrease in that. Okay, and then also there was a significant decline in the pulsatility index. These are all indices that reflect blood flow to the uterine vessel. So once you have a decrease in them with an increase in resistance index, okay, then the blood flow is decreased, and that will cause a decrease in blood flow to the uterine fibroids and cause a decrease in myoma size. So when and how should we use GnRH agonists? Primarily, we use them for 3 to 6 months. I'm sure my colleague who will talk about extended use for some other conditions, but for uterine fibroids, we don't aim to exit 6 months. For most of us, 3-4 cycles, we'll be able to achieve our aim. And then it is meant to transition patients who are perimenopausal, or again, to prepare them for a definitive treatment. So the goal will be to induce amenorrhea or decrease blood loss to be able to improve the preoperative hemoglobin, and also to decrease the uterine sizes, and we'll see the use for them very soon, and improve the overall health for the woman and the bulk symptoms. So in 1987, West et al. Directly used Zoladex, as we know it in Ghana, okay? And the sample size was not too big. They have 13 patients, but of course, looking at where they were working, 13 was big enough for them. And if you look at the number of days they follow these women, I think it is quite important. So they gave Zoladex 3.6 milligrams, as we have them in Ghana here. They gave it subcutaneously at 4 weeks interval, just as we do here, and followed them up for 6 cycles. Now, they found out that after the 6 months, there's a mean reduction in tumor volume by 55%, with a range of 38 to 48%. And that was quite significant. Now, the important thing to remember is that most of us are afraid of the flare effect. So we think that if you give it, you're going to have exacerbation of symptoms within the first month. But if you look at the data they have, they found out that the most important period within which they achieved the maximum volume reduction was within the first month, the first treatment cycle. So yes, there's flare, but there's followed that it's a sustained decrease in the levels of the menopause or the reproductive hormones. Okay. Now, again, we worry about some side effects. Out of these 13 patients, only one stopped the treatment, and it stopped because of massive blood bleeding. The reason was that she wasn't evaluated to have significant submucosal fibroids, and that's why they recommended that we should make sure we rule out submucosal fibroid before we start our treatment. Okay, now Zoladex can also be used in the preoperative period. So that same study, I think there was a study here that wasn't, okay, it didn't show up. So there was one study that I think was Hanakan et al. It wasn't picked. They did a preoperative assessment using Zoladex, and they found out that within 3 months, there was a significant reduction in the volume of the patients, and they were able to go and do minimal access surgery for these patients. Again, they also achieved more than 50% reduction, okay, in the tumor part. And then most of them occurred within the first few days of treatment. Now, yes, all patients experience some mild vasomotor symptoms, but the important thing is that they were not severe enough to discontinue treatment. So we should not be afraid if you are using the genetic analogs for 3 to 6 months. Now, again, this is just to tell us about the timelines. So in 1990, Candiani et al., again, curious about how soon you have to give this, how soon you have to wait before you get relief, proved that when you use genetic analogs, the optimal effect is felt within the first, it's felt within the first month of treatment. Okay, it doesn't matter whether it was started in the luteal phase or in the follicular phase. And then when it comes to reduction in tumor size, again, Friedman et al. In 1991 also showed that within the first 2 months, there was a significant reduction in tumor volume. So we don't have to give for so many months before we get the response that we want. Again, Cochrane data review in 2020 has clearly proven that the GnRH agonists were very beneficial when used in preparing a patient for myomectomy. The evidence was shown that there was decrease in operative time and there was decreased blood loss, and they're able to use minimal access surgery or decrease or move from midline incision to transverse suprapubic incisions for some of these patients. And so they recommended it. And then Park et al. In 2022, just last year, also showed that 3.75 milligrams of goserelin, which is Dosinase, injected twice. Okay, that's 4 weeks apart. Just for 2 months was associated with significant reduction in tumor bulk and was good enough for minimal access surgery to be done. So Cochrane database 2017 reviewed all the data and came with this conclusion that GnRH analogs, or agonists rather, given prior to surgery were associated with pre and post-operative HB rise and hematocrit. They also found out that the uterine volume and size significantly decreases, as we've seen earlier. And then hysterectomy and myomectomy were easier to do, shorter operative time, and then shorter hospital stay. Now, the fear that when we use myomectomy, there will be loss of, when we use GnRH analogs, there will be loss of the capsule space was not recognized in this, was not noticed in the studies. And so there was a decrease in blood loss and shorter operating time. The challenge, however, is that some smaller nodules may totally disappear. And then once you start the medication, it may bounce back, and then you may not have seen them to remove them. That's just a challenge. Now, this is specifically done for myomectomy, and this was published a couple of months ago. Now, it says that they did the study because myomectomy, as we know, is one of the most iatrogenic surgeries in gynecology. And most of these patients, we are doing myomectomy because we want them to conceive. So if you do a surgery and it comes up with dense adhesions, then what have you done? So they decided to find out what are the risk factors for myomectomy, for adhesion after myomectomy. So they found out that position and the size were the two most important determinants. So posterior nodules are likely to incite adhesion formation. And then when the fibroid nodules are more than 3 centimeters, for every centimeter after that, there's increased risk in adhesions. And so if they were able to use any medication to decrease the tumor size significantly, then it means then that the adhesion formation will decrease. And so they use genetic analogs and prove that. So they recommend that genetic can safely be used before myomectomy. Now, we're always worried about the side effects. Yes, if you use genetic analog for prolonged periods, there's a risk of vasomotor symptoms, but most fearsome will be the osteoporosis and osteoporotic fractures. So there's always that talk about add-back therapy. Okay. Now, for most users for fibroids, you don't have to worry about that. There may be some mild vasomotor symptoms, but not severe enough. And within up to 3 to 6 months, you don't run the risk of developing osteoporosis. So you're comfortable, you can use it. But for extended use, yes, you can talk about add-back therapy. And there are different types of therapy used, steroid and non-steroidal add-back therapy. Okay. Now, in 2023, updates concluded that FDA has approved the use of Gynae plus 0.625 milligrams of conjugated equine estrogen, which is primary that we all know. And then non-etindrone acetate, 5 milligrams, okay, to be used as an add-back therapy. The other add-back therapy regions, but this is what FDA has approved because of its efficacy. Okay, again, that was to show the relative, but it didn't show up. Okay, so some studies have demonstrated endometriosis symptoms improving, okay, significantly with GNI analog. But then when you use a high dose, okay, therapy, the fear is that you may run the risk of increasing the endometriosis. And so there's a notion that we can use low dose in this. However, the results were not good when they use low dose estrogen combinations. So the recommendation to use either GnRH with what we saw earlier, or just GnRH with non-etindrone acetate, okay, as add-back therapy. And that's what I meant by FDA does not recommend the use of low dose progestogen estrogen combinations. So let me summarize by saying that fibroids are very common, and the exact prevalence is difficult to determine in our environment specifically. Most are asymptomatic, but if they are symptomatic, then we need to think about management of these patients. Before we resort to surgical management, we should think about managing them medically. And there are various pharmacological methods available, but GnRH agonists are proven to be very effective in symptom relief, decreasing tumor balls, and make surgery easier, especially for those of us who have been dealing with very bulky fibroid masses. This may be very helpful for us. Now, monthly subcutaneous depot injections of Zoladex are more convenient to take because they are doing
half of the world says this, the other half of the world says something else. Even the consensus agreements don't have consensus, but we'll work it out. Disclaimer from Sharon. Okay. Hans Rudolf Tinenberg described endometriosis as a paradox. He says it's one disease that has many faces. In other words, it's a chameleon. Often suspected, not commonly diagnosed. At diagnosis, it's hard to estimate the extent of the disease. So it's a bit like an iceberg. What you see above the water has no relation with the size of the problem that is under. It is benign, but it's infiltrating. It's hormone dependent, but yet cannot be treated by hormones. The hypotheses of its origin are multifold. The treatment options are very limited. It takes several years between the onset of symptoms and diagnosis, and yet affects women in the time-limited period of their reproductive years, thereby stealing their fertility. As we all know, it's a disease where tissue similar to the line of the uterus grows outside the uterus, causing pain and infertility. That's the WHO's description. Howard described it as a chronic gynecological condition characterized by the presence of tissue with a histological appearance of endometrial glands and stroma outside the endometrial cavity, which often causes dysmenorrhea, dyspareunia, chronic pelvic pain, and often associated with infertility. Most common cause of pelvic pain occurs in about 30 to 40% of infertile women. Generally, is estimated to affect approximately 10% of women worldwide. Peak in this incidence is between 30 and 34 years, but symptoms can occur during adolescence. We have a bit of a problem with the whole incidence issue because whichever figures you get are usually of people that have reported in hospital because they have got one problem or another. But there are quite a number of people who suffer without actually coming to the hospital. So I suspect that it is more than actually what we think it is. There are certain barriers to diagnosis. In certain cultures, there are taboos about discussing menstrual issues, normalization of menstrual pain in various societies, sociocultural barriers to health-seeking behavior, dismissal of menstrual pain by medical professions. Yeah, that's in our courts. As a result, those that are diagnosed are actually those that choose to go to hospital, those who can afford hospital, and those who meet a doctor that recognizes the disease. Dr. Ntimio just mentioned the fact that more and more cases are coming to the clinic. But that's also in partly because more and more doctors are more conversant with the symptoms now, that when they see it, they recognize the fact that this problem requires certain kind of attention and therefore sends the patient there. If you don't get the right diagnosis from the beginning, then we don't get a solution. So what happens in ectopic endometrium? There's increased expression of aromatase enzyme and decreased expression of 17-hydroxysteroid dehydrogenase. There's, as a result, increased local production of estradiol. The sum consequence is a marked increase in the locally bioavailable estradiol concentration in the ectopic endometrium tissue. The estradiol stimulates the production of prostaglandin E2, which further stimulates aromatase production, which further stimulates estrogen production, and the cycle just goes on like that. And these findings support the capacity of endometriotic lesions for estradiol biosynthesis and therefore substantial treatments aimed at promoting a hypoestrogenic peritoneal microenvironment. I guess that's self-explanatory. GnRH is a decapeptide, as we were told earlier, released in a pulsatile fashion from the hypothalamus. The pulsatile fashion is important. It acts on the pituitary plasma membrane receptor and causes release of FSH and LH, which stimulates the ovaries to produce estrogen. The pulsatile nature of it causes the stimulation of these hormones. So it has been discovered that if they are produced in a non-pulsatile manner, they actually suppress. They have a suppressive effect. The half-life of the endogenous GnRH is just 2 to 4 minutes. And that contributes to its pulsatile nature. And this is due to renal clearance and degradation by peptidases. These peptidases cleave at positions 6 and 10 of the decapeptide. And to make analogs, we take advantage of that knowledge. So if you change the proteins, the amino acids at peptidase 6 and 10, the end result is that you can change the behavior of the GnRH, the artificial GnRH that has been produced. So it affects the duration of action. It affects its pulsatility behavior, and also affects its potency. Like we said, it causes an initial flare, but the type of amino acid affects the way it works, and therefore it can be given intranasally twice daily with nafarelin. It can be given subcutaneously with leuprolide and goserelin, and it can be given as an intramuscular injection as well. All these behaviors are because of the kind of protein they put in those one or both of those two locations. The goal of medical therapy in endometriosis is generally to reduce circulating estradiol pharmacologically, and that is what these drugs do. To an extent, that would improve the disease, but prevent unnecessary bone loss, and therefore resulting in an atrophy of the endometrial implants. The studies demonstrated quite early that agonists are as effective as the previously FDA-approved danazol, and that allowed it to also get its own approval. And the advantage of it over danazol was that it didn't have the androgenic effects that danazol had. Effectiveness. In an open-label multi-center study with 146 patients with confirmed endometriosis, they gave Zoladex every month for 6 months, and they found a reduction in subjective score and total pelvic symptom score by 86% and 93% respectively at the end of the treatment. They found a maintenance of the score. They found a maintenance of the score at 1/5 of the pre-treatment value throughout the follow-up period of 48 weeks. 107 of these people had second laparoscopy at the end of the therapy. 54% shows reduction in implants and adhesions by at least 50% or more, and 31% had complete resolution of visible deposits. 24 out of 64, that's 31% of previously infertile patients successfully conceived within 12 months after discontinuation of therapy. As a therapeutic method, it is quite effective. However, to balance that effectiveness comes with certain side effects, and they are significant. And these are a result of low estrogen. Patients usually complain of vaginal dryness, vasomotor symptoms. The hot flashes can be really concerning. Decreased libido, mood changes, irregular bleeding or amenorrhea, and reversible reduction in bone mineral density. After 6 months of administration, you can lose between 6 to 12% of your bone mineral density. And that is what initially restricted it to 6 months of use. So the recommendation was that you can give it for 6 months for this purpose, after which you can't give it anymore. However, the solution to this is to ensure that we can maintain the hypoestrogenic states, but yet we can continue to have an efficacious effect on the endometriosis. And that was done by add-back, which essentially is adding a low-dose estrogen or progestogen or testosterone to the GnRH analog to minimize the side effects. And a variety have been tried. Zoladex plus 100 milligrams medroxyprogesterone acetate per day, or Zoladex plus 0.3 milligrams, or 0.635 milligrams estradiol plus 5 milligrams medroxyprogesterone acetate per day, 17 beta estradiol 2 milligrams per day, plus 1 milligram norethindrone acetate, norethindrone acetate 5 milligrams per day alone without adding the estrogen component. Tibolone 2.5 milligrams per day. That's a synthetic steroid that has got weak progesterone. It has weak progesterone, estrogen, and androgenic activity. You can have 5 milligrams per day transdermal estradiol via patch. You can have 300 milligrams per day intranasal estradiol spray. And you can have the estradiol spray plus 275 micrograms of testosterone spray per day. All of these would result in giving you a little bit more of the estrogen that would ensure that you would have less bone mineral density effects, and that would allow you to extend its use from 6 months to a year. The second rationale actually is also, it's like an explanation of the first one, is the estrogen threshold hypothesis proposed by Barbieri in 1992. And he suggested that there's a key therapeutic range of estradiol, which is between 30 to 50 picograms per ml, at which bone turnover by osteoclast is minimized. And yet the endometriotic implants are adequately deprived of the stimulatory effect of estrogen to block the growth of endometriosis. And therefore, if whatever we gave, whatever add-back we gave would allow us to remain between the 30 to 50 milligrams of estradiol, it would ensure that you can achieve the effect you want, but yet we have a minimization of the side effects. So Agrawal et al. In 1997 tested this, and they did a study where they compared naferralin 400 micrograms daily and leuprolide 3.75 milligrams monthly in terms of efficacy and side effects. Both arms showed an improvement in the symptoms that the clients had to an equal degree, but the side effect profile differed significantly between the two groups. The leuprolide arm had a significantly larger reduction in bone mineral density and increased frequency of vasomotor symptoms. When they measured their estrogen levels, they discovered that in the naferralin group, the estradiol levels remained higher, around 30 picograms per ml, than in the leuprolide arm, which was 15. Both therapies were equally effective at improving endometriosis pelvic pain. The differences observed between the two groups, however, could be explained by the estrogen threshold hypothesis and reinforce the concept that complete suppression of the hypothalamo-pituitary ovarian function was not necessary for clinical benefits and maintenance of vasomotor function and bone mineral density. So it allows us to find a way to get an extended benefit in using Zoladex, for example, to treat our patients that have got endometriosis. So now that we know that we can use it, there are a few questions that we have to ask ourselves and try and find solutions to. Questions that will affect our daily practice. Is empiric treatment of endometriosis with these agonists allowed despite no surgical diagnosis? Traditionally, diagnosis has been by laparoscopy and histology. There have been further studies that have suggested that we can actually use ultrasound. There are recommendations that there are some ultrasonographic findings. If you find what they call the Indian warhead chief, the hats, the furthest thing that they have on their head, if you are doing an ultrasound and the person has got deep endometriosis, you can see that kind of sign, or the lack of sliding of the rectovaginal mucosa when you are doing an ultrasound would give some of those findings. So laparoscopy, having to do a laparoscopy is no longer being absolutely required before you can make a diagnosis of endometriosis. Ling et al. Randomized 100 women to receive placebo or leuprolide over 3 months for suspected endometriosis in patients who had moderate or severe pelvic pain. In the intervention group, there was significantly more improvement in all pelvic pain measures when compared to placebo. All subjects had laparoscopy. 78% of the leuprolide group and 87% of the placebo group had surgically confirmed disease. They concluded, therefore, that empiric treatment of GnRHA can be started when endometriosis is suspected. And since 1999, the American College sanctioned the empiric use of GnRH analogs prior to surgical confirmation of the disease. Post-operative use of GnRH analogs, it has been found that you can prolong your patient's pain relief after surgery. Especially when you found that when you did a surgery and knew that there were some nodules left. The studies showed that patients who had got 6 months of Zoladex treatment post-surgery were pain-free for up to 2 years. The patients that did not get had a resumption of their pain in less than a year. It also results in a reduced recurrence rate. And the conclusion, therefore, is that medical management of endometriosis post-surgery significantly prolongs the recurrence of symptoms following surgical management. So in summary, as clinicians, we should have a high index of suspicion for endometriosis, especially in clients that have chronic pelvic pain, severe dysmenorrhea, and infertility. We have to add symptoms like those who've got cyclical pain in their chest and pleural effusions and things of that sort. And it's interesting to note that men too can get endometriosis, which totally destroys the retrograde menstruation argument. But in those men, there are usually people who have had high-dose estrogens for prostate cancer treatment, or people who have had repeated surgery in the pelvic region, especially hernia surgeries, and then people who are obese. So don't be too surprised if a man comes with symptoms that, or a mass in a certain area that doesn't quite make sense, especially in the pelvis. And don't be ashamed to say that, oh, you think it's endometriosis. It is possible. Early diagnosis is paramount to providing women with specialized interdisciplinary care to maintain or improve quality of life. Once diagnosed, empirical treatment with GnRHA is permissible without laparoscopy. Add-back should be encouraged from the second month of treatment, especially if you intend to continue your treatment for longer than 6 months. At least give yourself that option if you start early. Consider adding calcium and vitamin D also, because we are in our part of the world, we are very notorious for having very low vitamin Ds. It's amazing how many people's vitamin Ds are low. The combined OCP is readily available, and it's an okay choice if you can't find some of the more complex ones. You can if you extend it to 12 months if add-back is added, and post-surgical administration can extend the pain-free interval and reoccurrence by more than 2 years. Thank you very much.
Thank you very much, Dr. Paddy. I believe we've all learned something on his presentation. So we'll take the third speaker, and after that, we'll answer all your questions from all the presenters. So Dr. Chike Onozu, if I got the name right, is our third.
Thank you very much. Okay, so I've been given the most. Good evening, everybody. First of all, thanks to FESOG and AstraZeneca, I've been given the most difficult task this evening, and it's interesting that my bosses have been given these topics, and I was given the the topic for the gurus. But I'll try my best to do as best as I can. So I've been given the responsibility of discussing the role of GnRH analogs in pituitary downregulation during IVF. And of course, Fertility Society of Ghana, we are a fertility society, so we are engaged in the management of patients with fertility issues. So this particular presentation is to, are we good? My slides. Okay, all right. So yes, I was just saying that we have the responsibility of knowing the roles of GnRH analogs. And when I get into the topic, I would explain why analogs now represent both the antagonists and the agonists. I have quite a number of slides. They are now loading, so just give us a few minutes. But I also want to say that I'm honored to be in the midst of my mentors, my teachers' teachers, and then my teachers' teachers. And it's an honor for me to be here, and I appreciate the opportunity. Sharon, a minute. Okay, right. Thank you. So, no disclosures, no conflict of interests. This is my outline. Basically, I'm just going to go through the introduction, and I'm really sorry, my slides seem to be a lot, but I'll try and run through them pretty quickly within the time allotted to me. So there's an introduction, there's an overview of infertility. We'll talk about assisted reproduction, in vitro fertilization overview, the menstrual cycle and the HPO axis, and then we'll delve into the GnRH analogs themselves. We'll talk about the agonist and antagonist. We'll talk about the protocols, and then we'll talk about some relevant research findings, and then we'll conclude on that. Okay, so we know about infertility. I don't think I need to teach anybody here about infertility, but basically we know that it's the failure of a couple to achieve pregnancy within 12 months of unprotected intercourse. And this phrase here is very important because it was added recently in the 2022 ASRM Congress, that the therapeutic donor insemination in women younger than 35 or within 6 months in women older than 35 is an add-on to the definition of infertility. So for the students and the young people here, if they ask about the definition of infertility, please bring in that little caveat there, therapeutic donor insemination. But the age ranges remain the same. Remember that even though we start the definition with a couple, we end it with women. And that's because women have a biological clock. You can find sperms even in a man in a coffin, but women would definitely run out of eggs at a point in time in their lives. So let's remember that part of the definition. And of course, globally, we are talking about 15% of couples. And in sub-Saharan Africa, we are talking about up to 30% of couples. And these numbers rack up to about 48 million human beings on Earth, or couples on Earth looking for babies, and that's quite a huge population. Now in Africa, in Ghana, especially West Africa, we don't have so much data when it comes to infertility. But some recent research in Ghana puts the numbers at 11.8 to 15% of couples having issues with fertility. And it means that that's a large cohort of couples who come to us every day seeking for help for babies. Now, we know about the expedited, investigation in women who are older than 35. And then we also know about the conventional classification of infertility, 30-30, 30-10. But it's very important to note that now my colleagues, the men, are contributing 40 to 50% when it comes to fertility and infertility. That's a huge, huge, huge chunk. And in fact, it's very unfortunate that we still find women as the first presenters at the clinics when it comes to infertility. The men should actually show up before the women. And I believe that none of us here would manage a female alone once she's a member of a couple when it comes to infertility. Now, we know that IVF has come in and has become a source of hope for so many couples who are battling infertility. We all know about this slide. We know about the causes of female factor infertility. We know about the ovarian factors, which would also dovetail into the hormonal factors. We know about tubal factors, uterine factors, and the cervical factors. Now, for the male causes of infertility, we have this whole pie chart here giving us the distribution. But there's a very important, piece of the pie, and that's the unexplained infertility, which contributes or constitutes about 34%, more than a third of male factor infertility. Now, that's a problem, and I'm sure most of us struggle when it comes to men and infertility issues in our consulting room. So please take note that you may not find anything leading to the semen derangements in many of our men who come in with infertility issues. Now, assisted reproduction. Now, we know that assisted reproduction generally is any method you employ to try and improve the chances of a couple who are trying to get pregnant. And we know that you can approach assisted reproduction. Okay, before I even go there, we know that assisted reproduction assisted reproductive technology is a subset of assisted reproduction. So assisted reproduction is the bigger title, and then ART constitutes a part of the assisted reproduction, whatever is there now. So we have fertility medications, which we can employ, and fertility medication usually would include ovarian stimulators. So we have ovulation induction agents, where we have clomiphene citrate, we have letrozole, which I'm sure most of us are using now, and of course we have the gonadotrophins. Then we have the maturation and or release phase, where you can do or you can achieve this using HCG or GnRH analogs or GnRH antagonists or agonists. Now, when it comes to assisted reproductive technology, let me say that this slide has artificial insemination as part of ART, but that's actually been taken out in recent times. So in ART or assisted reproductive technologies or techniques, we are basically focusing on in vitro fertilization with ICSI or or conventional embryo transfer, and all the other methods of IVF. So please remember that artificial insemination wouldn't constitute a constituent or a component of ART in contemporary times. So, ovulation induction. Basically, this is what we do most commonly in our consulting rooms and our clinics, and this can be done at the most basic healthcare delivery center, where you just need to administer some ovulation induction agents. Of course, you must have evaluated your patients and you must have diagnosed anovulation, oligo-ovulation, or some kind of ovulation disorder in this patient. And then you can introduce your ovulation induction agents. You can go with the orals only. Letrozole is put there now because that's almost like the gold standard when it comes to ovulation induction because of the benefits over clomiphene citrate. But of course, clomiphene citrate still plays a big role in our ovulation induction when it comes to orals. So you can use your ovulation induction agent. You can trigger ovulation when your follicles seem to have matured to the appropriate size for ovulation. And then you can decide to do either timed intercourse or artificial insemination or intrauterine insemination, whichever one you want to call it. And then we have ovulation induction using oral agents plus the gonadotrophin. So letrozole or clomid, starting from day 2 or 3 of the cycle to about day 6, 7. Then you can augment with your gonadotrophins. And then, of course, I would say that you should be following up your follicles when you're doing an ovulation induction. It doesn't have to be that, but that's best practices. Following up your follicles, getting to the appropriate size for ovulation, triggering ovulation with HCG, and of course the dose ranges from 2.5 2,500 all the way to 10,000 international units, and then deciding on whether it's timed intercourse or artificial insemination for these patients. Now with ARTs, we would just say simply that this is any fertility related treatment where you manipulate the eggs or embryos. And that's why the IUIs have been taken out of the definition of assisted reproductive technologies. So you're manipulating you're manipulating eggs and manipulating embryos. If you manipulate sperms and inject into the woman's uterus, that is not considered a type of assisted reproductive technologies. Sorry. And of course, if you manipulate the cycle, but then you don't go ahead to retrieve eggs, we still will not qualify this as assisted reproductive technologies. Of course, cycles can be cancelled, cycles can be suspended, but in the true definition of ART, you are manipulating eggs or embryos. Now, it usually starts with cycle control. So you take hold of the cycle, most times using your oral contraceptive pills. You downregulate using our GnRH analogs. You control the ovarian stimulation using your gonadotrophins. Then you retrieve your eggs, usually in the theater or in the IVF theater. Fertilization, of course, happens in the IVF lab. You culture in the incubator, and then finally transfer your embryos when the endometrium is ready for receiving the embryos. So these are the steps in ART. I'm sure we all know this, so it's just a recap. And of course, we know that the complications of ARTs include hyperstimulation and multiple pregnancies. Multiple pregnancy may not be an issue in this part of the world, but out there it's actually a big thing. And that's why we are heading towards the single embryo transfer in most of the countries. And then we know that even though these complications exist, there are means of preventing them in the whole ART cycle. These are the indications for ARTs. We already know this: male factor infertility, tubal factor infertility, ovarian insufficiency, ovulatory disorders, diminished ovarian reserve, surrogacy, unexplained infertility, endometriosis, like Dr. Paddy came through. Patients with endometriosis would need or may need some kind of ART. Sex selection, controversial, yes. Genital tract malignancies. If a woman has ovarian CA and you want to preserve her fertility, you may want to retrieve the eggs, store them for whenever she's fit to carry a pregnancy. Pre-implantation genetic testing becoming an integral part of ART now, and it's just to help rule out aneuploidy, structural gene anomalies, and monogenic disorders. Of course, gene therapy we know about. Same-sex couples, very controversial, but it's getting closer to us, so we should all get ready for this. Fertility preservation, and then posthumous reproduction. People who pass away and still want to preserve fertility. These are all big issues in other parts of the world, so let's get set for this. Now, Louise Brown I hope I pronounced the name right. She's now 45. And I remember when we were in med school, we spoke about Louise Brown. Then she was about 30. And we're all talking about her having children naturally. She has 2 sons now, we know. And it's been 45 years since the first IVF baby was born, and that's Louise Brown in the United Kingdom. And since then, there have been over 8.5 million babies delivered worldwide. And this number is relevant because just last year, it was about 7 million. So 1.5 million more babies have been added to the number of babies delivered by IVF. And that's relevant. The numbers are going up. Now we know it's globally accepted. There were certain tribes and certain nationalities that wouldn't accept IVF or ARTs, but now it's accepted generally worldwide. And we know that day after day, new protocols are coming up to improve live birth rate and client experience. So we know that IVF is the most common ART. First protocol employed in 1980, that was Louise Brown's protocol. And her delivery in 1981 was a landmark moment in IVF. The protocols usually involve a complex interplay of various hormone modulators to enable us get multiple follicles recruited in one single cycle. If you leave the body to do its own thing, usually 1 follicle will be recruited, maximum 2. But in IVF, the whole aim is to recruit as many follicles as possible and increase the number of embryos you will be able to achieve from fertilization, just to improve the chances of conception, and of course to store some of these embryos for future embryo transfers. Now, the success of interventions are highly dependent on these exogenous hormones and their analogs, and gonadotropins are the main agents when it comes to follicular maturation. But these gonadotropins will not be useful if you do not modulate the pituitary gland to take hold of the body's natural production of the gonadotropins, and then, of course, end up with your IVF protocol. So GnRH modulation of the pituitary gland is pivotal in the IVF protocol and is the bedrock of ovarian stimulation protocols. And that's why we're talking about that today. We know about controlled ovarian stimulation. It helps with the number and quality of oocytes, prevention of ovulation due to the LH surge. You're reducing cycle cancellation, which is very important because if you don't have controlled ovarian stimulation, you may end up canceling cycles because of the risk of hyperstimulation and other complications. And of course, it helps us reduce the dose of gonadotropins, reducing costs, helps us in the timing of oocyte retrieval, improves implantation rates and pregnancy rates. But IVF has its challenges, and you cannot have IVF without the worry or the concern about the complications. You may have a poor response, like we see on the first quadrant up there. You may have an overly exuberant response, like we can see in the lower one, which is ovarian hyperstimulation. You can have premature ovulation. Despite all your attempts to prevent ovulation, you may have an LH surge and then ovulation. And of course, cyst formation is another concern you have when it comes to this. Now, this is just a brief schema of the menstrual cycle. We all know this, but I'll just go through briefly. At the beginning of the cycle, 1 oocyte is recruited, following an interplay of the gonadotropins, and that's the endogenous gonadotropins and your GnRH from the higher centers. There's an initial surge of your estrogens just before your LH surge. The LH surge happens just before ovulation. Egg is released at ovulation. There's a small peak of FSH around the time of the LH surge, and then estrogens would have a second peak in the luteal phase, and then of course progesterone takes over after luteinization of the released follicles. So this is just a brief schema of the natural menstrual cycle. Now, when we give GnRH analogs, we are basically trying to take over the natural menstrual cycle so that we can manipulate these hormones and in the process get as many follicles recruited as possible. The HPO axis, we know about the HPO axis already. We have the hypothalamus as the highest center. Just below that is the anterior pituitary. So GnRH is typically produced from the hypothalamus, comes down to the anterior pituitary. The gonadotropes in the anterior pituitary will then lead to the release of FSH and LH. LH has more effect on the thicker cells, which helps in the production of androgens. FSH on the granulosa cells, which helps with the production of estrogens, and inhibin. Inhibin has a selective inhibitory effect on the pituitary same as estrogens. So it's only results in the negative feedback for FSH. And then, of course, your estrogen can then have the negative feedback on the pituitary and the higher center, which is the hypothalamus, both an inhibitory and a pro production effect on those two centers. So this is just a brief schema, and this becomes very important when we get to the point where we have to talk about FSH and the menstrual cycle. So now, so this is just another illustration of the HPO axis, which we just spoke about. Same thing we just talked about a second ago. And then this is about the neuroanatomy of the HPO axis. We have our paraventricular and our supraoptic nuclei in the hypothalamus, and then along those capillaries down towards the anterior pituitary, and then its effect on the pituitary gland to release the gonadotrophins from the gonadotrophs in the pituitary. Now, the physiology of GnRH generally. So GnRH was previously referred to as the luteinizing hormone releasing hormone. So that was the old name. If you read some old texts, that's what you actually find. And it's the key regulator of the reproductive axis. Now, it's released in a pulsatile fashion. Usually the half-life, as Dr. Paddy said earlier, 2 to 4 minutes, but that can actually change depending on the time of the cycle. And that determines the pattern of secretion of the gonadotrophs, which we've spoken about already. Gonadotrophins regulate both the endocrine function, that's estrogen and testosterone release in male and females, in females and males respectively, and gamete formation in the gonads. So your ovaries and their production of the oocytes, your testes and the production of the sperms are regulated by estrogen and testosterone, which usually are regulated by the gonadotrophins, FSH and LH. Now, GnRH is a decapeptide. That's a 10 peptide, structure, and is isolated, or it was isolated from porcine hypothalamus 5 years ago, 5 decades ago, sorry, not 5 years ago, almost 50 years ago. Now, the pulsatile secretion of GnRH is regulated by the circulating levels of estrogen and testosterone. So they have the negative feedback on the pituitary gland and the negative feedback on the hypothalamus. And the latter is what would regulate GnRH release. Now, this is the GnRH release through the menstrual cycle. And this is very, very important because it tells us where we can catch or capture GnRH or take over GnRH function through the course of the menstrual cycle. Now, when we start off at the beginning of the menstrual cycle, we see that the pulsatile release of GnRH is more of a controlled release, usually the 2 to 4 minute release. And then at that point, FSH, which is the dotted graph you can see there, starts to rise. Now, when FSH starts to rise, it then, as its name goes, starts to recruit the follicles from the ovaries. Now, as FSH starts to rise, the estrogens, that's what we can see in the lower graph there, also starts to rise gradually, because what then happens is that GnRH pulsatility starts to go up, and that triggers the pituitary to release the FSH, which we've talked about already, and then estrogen starts to rise gradually. Now, when estrogen starts to rise, what then happens is that it competitively and selectively inhibits the FSH production. Now, if this doesn't happen, you're going to probably recruit half of the eggs in your ovaries in one cycle. But because estrogen selectively inhibits FSH release, the dominant follicle is then selected. Now, that dominant follicle is what would then grow through the cycle. And then as we get closer to the mid-cycle, remember that there was a selective reduction or inhibition of the FSH release. So LH was actually left behind. So the LH starts to rise, and then we get our LH surge. Of course, because you have told the pituitary that FSH levels have to drop, it sends a message back to the hypothalamus to increase or jack up the dose of or the amount of GnRH that is released. And that's what happens around the mid-cycle. So GnRH pulsatility increases towards the halfway point of the cycle, and that causes more LH to be released. Remember that LH is not inhibited at this point in time. So LH surges, and then, of course, as it drops, ovulation happens. So when ovulation happens, of course, if there is no fertilization and your corpus luteum forms, then what then happens is progesterone is released. But remember that all through this, estrogen also gets another peak in the luteal phase because the GnRH is still being asked to produce more GnRH, and that also causes the ovaries to keep producing the estrogens. But when we get to the mid-luteal phase, when estrogen and progesterone levels tend to peak, they now send that negative feedback to the pituitary and the higher center, which is the hypothalamus, so that GnRH levels start to drop. And then they drop down all the way towards the end of that cycle. Menses happen, and then GnRH starts to rise again in the next cycle. So it's a very nice, beautiful, complex interplay of all the hormones involved in follicular recruitment, ovulation, corpus luteum formation. Of course, that's what causes the surge of progesterone because of luteinization of the oocyte that has been released. And then, of course, when your corpus luteum dies, then another surge of GnRH starts again. So that's the complex interplay. At the end of this, you ovulate, you menstruate if there's no fertilization and implantation, and then the next cycle starts again. Now, GnRH analogs. These are just synthetic peptide analogs of GnRH, okay? And as I said earlier in the presentation, we now classify agonist and antagonist as GnRH analogs. They cause significant inhibition of pituitary gonadotrophin release. So the endogenous release of pituitary gonadotrophins is inhibited by GnRH analogs, and that is the basis of their function. This reduction in gonadotrophin secretion now causes consequent reduction in estrogen and androgen release. Okay. Now, ultimately, what then happens is that you've literally cut off the natural production of FSH and FSH and LH, and then of course estrogen and androgen production also reduce, and then you can decide to take over and give your exogenous gonadotrophins for your IVF cycle. Okay. Now, research has shown that the agonists and antagonists have similar ultimate effects in the reduction of GnRH, in the reduction of gonadotrophin productions endogenously. And pure antagonists have a more rapid onset of action, and they lack the initial surge, which many people are worried about when it comes to GnRH analogs. And this is very important, and we'll talk about it a little more when we get to the point of explaining how each of these work. That's the agonist and antagonist. Okay. We already know that the agonists are more associated with the initial flare. So let's delve into the analogs. They can also be used in the treatment of other conditions that have been talked about by the previous speakers: endometriosis, uterine fibroids, precocious puberty, hyperandrogenism. And then, of course, in 2023, you cannot talk about GnRH analogs without talking about sex suppression for transgenders. So those who are trying to change their sexes, GnRH analogs remain a very important component of their management. And I think that we all should start getting abreast with this, because they are coming and they are pretty close to us. Of course, we know about prostatic cancer and the effect of GnRH analogs in suppressing androgen production. Very, very important in the treatment. So the mechanism of action, we have an initial flare, usually more common with agonists. We have an upregulation, which is an increase in the number of GnRH receptors. Then there's an internalization phase where the analog receptor complex internalizes into the cells. Downregulation, which then results in the GnRH receptors reducing in number. Refraction is where the pituitary now becomes refractory to any stimulation by endogenous GnRH. And then hypogonadism results in the reduction in circulating gonadotrophins. Just a little comparison between the agonist and antagonist. So for the agonist, we have an initial flare, we have the receptor downregulation, pituitary desensitization, and slow reversibility. That's compared to the antagonist, which doesn't have the initial flare, but competitively blocks the receptor. There's competitive inhibition and then immediate suppression. So they tend to act a little quicker than the agonist. But because of this, their reversibility is actually more rapid compared to the agonists. This is just another schematic representation of what we just explained in the prior slides. Okay, so let's talk about the agonists. So the agonists, forgive the tautology, but they act as agonists of the GnRH receptors, and usually they come in with the suffix relin. So most of them will have relin as their suffix. They work by downregulating the HPO axis and preventing LH surge. Now, they do not quickly dissociate from the GnRH receptors, and that's why their effects tend to fizzle out a little slower than the antagonists. And usually this is what causes the flare, which increases the LH levels initially by up to 10-fold. But after continuous administration of the agonists, what then happens is that there's a hypogonadal effect, which is very, very profound. And that leads to the suppression of the endogenous FSH and LH. Now, they have been an integral component of the IVF-ICSI cycles. And of course, we know that the very early IVFs had GnRH agonists as their main GnRH analogs. And they can be administered as oral, nasal sprays, vaginal pessaries, and depot preparations, just like we spoke about earlier. So these are just examples of the agonists we know. And leuprolelin, goserelin, and buserelin are the most common we use in Ghana. Now, the other clinical application of the GnRH agonists have been spoken about by our previous presenters, and we've spoken about that already, so I don't think we need to belabor the point. Now, how would you know that your downregulation has been successful? Now, there's a rule of fives in this, where the expectation is that when you do your ultrasound at the beginning of the cycle, the IVF cycle, you should see less than 5 follicles on your AFC. The follicles should be less than 5 millimeters in size. Some people will say less than 3 millimeters in size. You should have an endometrial thickness less than 5 millimeters. Your estradiol level should be less than 50 picograms per mil. And then, of course, your progesterone level should be less than 0.5 nanogram per mil. So these are all factors you should take into consideration when assessing your level of downregulation and how successful your downregulation has been. Now, for the protocols. Now, GnRH analogs, we've spoken about the fact that they play a very important and invaluable role in controlled ovarian stimulation and inhibition of LH surges. And the protocols are threefold. We have the long protocol, we have the short protocol, and then we have the ultra short protocol. Now, there are so many sub-protocols of agonists, GnRH agonist protocols. There are so many new ones now, but we want to focus on the most common, the most widely used, and the easiest to remember. So let's talk about the long agonist protocol. Now, with the long agonist protocol, basically, you start your GnRH analogs on the 21st day of the 28-day cycle preceding the IVF. So you've decided on which cycle you're using for your IVF, and on day 21 of that cycle, you start your GnRH analogs. Okay. Now you can give it as a single dose depot, like we do with our Zoladex or goserelin, or you can administer 0.5 milligrams daily for up to 2 weeks, or until you trigger ovulation, depending on which protocol you want to use. Now you start your gonadotrophins, which are your exogenous gonadotrophins, FSH, HMG, whichever one you choose to use, usually on the second day of the cycle. And then, of course, you go ahead with your follicular tracking, you check on your endometrial thickness, and then you decide to trigger when you think your follicles are ready for trigger. During your assessment, at the beginning of the cycle, your endometrial thickness, just like we said earlier on, for optimum downregulation, should be less than 5 millimeters. And of course, your estradiol levels should be less than 50 picogram per mil. And these would indicate adequate downregulation. Now, of course, we've spoken about the follicular tracking, endometrial thickness assessment, and then, of course, people have their different protocols for the follicular tracking and the endometrial thickness assessment. We're not going to go into the different timing of your scans. I think that's very individualized. But you may want to profile your hormones in the course of the cycle. So you may want to check on your FSH, your LH, your estrogen, and your progesterone levels during the cycle. And then your trigger shot is given, and 34 to 36 hours. Actually, it's between 35 and 37 hours of HCG injection. You go ahead and retrieve your follicles. And remember that this final maturation can also be achieved with your agonist or your antagonist, not just HCG. Let's take note of that. Now, if you have increasing LH levels and increasing estradiol levels while you are assessing your patient, then you run the risk of hyperstimulation or premature ovulation. So let's take note of these. that during your assessment of the patient, your LH and estradiol levels are very important to help you determine when to cancel a cycle, suspend the cycle, or how to go about getting your follicles. This is just a representation of the long agonist protocol, where we start on the 21st day of the preceding cycle, and we can continue all the way till we trigger ovulation, till we give the trigger shot, and then go ahead and retrieve our follicles. The embryo transfer there, stated as 48 to 72 hours, is not done anymore. We know that most of our embryos are transferred on day 4 or day 5, morula or blastocyst stage. So let's take note of that. This is quite an old text. Now, what are the advantages of the long agonist protocol? Well, we know that you get better follicular recruitment, you get improved oocyte quality, improved follicular synchronization. So when you're stimulating your patient, you don't get too many follicles out of sync when it comes to the sizes. Most of your follicles are similar in size. There's a more flexible and convenient oocyte harvest for these patients. You tend to get more embryos, and then you get more numbers for cryopreservation, better endometrial receptivity, and this is very important for successful IVF, higher implantation rates, less cycle cancellation, and better opportunity for batching patients. Disadvantages, of course, is a longer treatment duration. So you're starting from a prior cycle and getting into your IVF index cycle. You use more ampoules and higher doses of the gonadotrophins, and this, of course, increases your cost of the procedure. You also run the risk of developing ovarian cyst in the course of your stimulation with the long agonist protocol. And then, of course, you get more hypogonadal or menopausal symptoms because of your long duration of administration of your GnRH analogs or agonist. Now, the short protocol. This tends to mimic your body's natural cycle. So you may prefer this for those who have responded poorly to a prior cycle or those who are a little older. Now, you administer your GnRH agonist along with your gonadotrophins at the beginning of the index cycle for the IVF. So nothing happens in the prior cycle apart from preparing your patient, doing your labs, and getting ready for your IVF cycle. When you start your gonadotrophins, you start alongside the GnRH agonist, okay? And then, of course, you would have done your assessment of the endometrium on day 2 or day 3 of that index cycle. You perform your follicular tracking as per other protocols, trigger, retrieve, transfer, as per what we've spoken about already. So this is just a brief representation of the short agonist protocol. So you're starting your agonist along with your gonadotrophins on day. You continue all the way till trigger. You trigger and then go ahead with your retrieval and your transfer thereafter. So what are the advantages? Well, this mimics the natural body cycle, and therefore is a shorter duration of administration of both gonadotrophins and your GnRH analogs. This helps you cut down on cost, obviously. You use fewer ampoules, lower doses, reducing your risk of hyperstimulation. You get better compliance from the patient. So if you tell a patient she's going to have injections from day 21 of one cycle all the way to day 14 or 13 of the next one, and you compare that to a patient who receives injections, 2 injections, of course, because she's getting gonadotrophins and the GnRH agonist from day 2 or day 3 of the cycle, you will definitely get better compliance with a short agonist cycle. And of course, if you have a patient who comes into the country, I'm coming in for IVF, she's disappeared and shows up in your consulting room that I'm ready for IVF tomorrow. Her period starts, you start your agonist, you start your gonadotrophins, and your cycle goes on. There are other patients who you're worried about the prolonged period of administration. You want to get your eggs quickly. She has CA ovary or CA endometrium. You need to get those ovaries out. You can go ahead with your short cycle, get your follicles, take out the ovaries, and then prepare her for embryo transfer when she's fit for the transfer. So those are the advantages of the short cycle or the short agonist protocol. Now, what about the ultra short? So as the name goes, you administer the GnRH agonist on the 2nd, 3rd, and 4th days of the index stimulation cycle. Now, your gonadotrophins will still start on day 2 or day 3 and continue on to trigger, but you're just going to give 3 doses or 3 days of the ultra short, of the GnRH agonist for the ultra short agonist protocol. Now, you go ahead with everything else, trigger, retrieve, transfer. And this, as you can see, is even shorter than the short agonist protocol. Saves more money, more cost effective, better compliance because you're giving far less injections. And of course, just like we said for the short agonist protocol, you can use them in patients who are out of town patients, patients who fly in and say they want to do the IVFs and fly back. And when you don't have that much time to take through your patient through the whole long IVF cycle. So this just shows us the various initiation of our GnRH agonists in the long protocol, short protocol, and then the ultra short protocol. For all of them, our FSH stimulation or our gonadotrophin stimulation starts whenever we plan to start on day 2 or day 3. The only difference is that day 21 of the prior cycle for your long protocol, day 2 or 3 for your ultra short for just 3 days, and then day 2 or 3 till trigger for your short protocol. So that's just a summary of our agonists. Now we come to our antagonists. Now these, as we said earlier, they competitively block the pituitary receptor sites, and then they induce a very rapid and reversible suppression of the gonadotrophin. So quick start, quick reversibility, makes it more flexible, easier to manipulate. Now they inhibit the pulsatile effect of GnRH endogenous release from the pituitary gland, just like the agonists do ultimately. And they are administered usually in the early follicular or mid follicular phase of your index IVF cycle. So you have no business with your prior cycle. Your focus is on the index cycle of the IVF. Of course, that means that you are reducing your duration of therapy. It means that your gonadotrophin requirements reduce, your duration of therapy reduces, cost reduces, and ultimately gives you a better opportunity for either an agonist or an HCG trigger. What are the benefits? Well, the benefits are the absence of a flare. Remember, we talked about the flare, with the agonist. You don't have this flare with the antagonist, and that's one of the major benefits of the GnRH antagonist. And of course, this means that you've reduced your risk of hyperstimulation, the absence of estrogen deprivation symptoms, the menopausal symptoms are far less, and it's a more patient-friendly protocol. So many patients would be more appreciative or would love these protocols over your long GnRH agonist protocol. You also will prefer GnRH antagonists for high responders because, of course, high responders increase risk of hyperstimulation. Your oocyte donors, you would also prefer your GnRH antagonist for your oocyte donors. Remember, we are not too concerned about the endometrium for the oocyte donors. And then for women who want to undergo fertility preservation, this is usually a better option for them. Now, if you have a poor responder, you may also want to consider your GnRH antagonist over your agonist because their initiation usually occurs after the commencement of gonadotrophin stimulation. And then this minimizes the impact on early follicular recruitment. So it's a better option when you have patients who are poor responders or who responded really poorly in a prior long cycle or short cycle. There have been randomized trials comparing the antagonists with other protocols, and they have shown similar IVF outcomes in both groups. However, because of the ability to assess ovarian reserves prior to deciding on whether to initiate gonadotrophin stimulation, the GnRH antagonists have a little disadvantage when it comes to that over the agonists. Ultimately, however, in 2022, a Cochrane review comparing GnRH antagonists and then the long protocol of the agonist showed that you had far fewer pregnancies when you use the antagonist protocol compared to the agonist protocol. So even though it's a more patient-friendly protocol, you will still have better outcomes with your GnRH agonists. So these are examples of the GnRH antagonists we know. Cetrorelix is the most common we use in Ghana. These are the other ones. Some of the names are quite a mouthful, sorry. But take note of Cetrorelix. I'm not going to mention the the trade name of Cetrorelix because of the forum we are in. Now, the GnRH antagonist protocols. Please, can I have some water? Thank Thank you very much, Dr. Fadi. Thank you. That's my boss. I have to step down to pick it there. So, sorry for the interruption. So, GnRH antagonist protocols. Of course, we know they are widely used in contemporary ART treatment. Initially, they were subject of experimental studies. There was lots of antagonism to the antagonists, pardon the tautology. But now they've integrated nicely into most IVF centers and IVF treatment protocols. Now we have two main types. There's the single dose fixed. Now it's called single dose fixed, not single fixed dose, for a reason. And that's the French protocol. Then we have the multiple dose, which is the Lübeck protocol, under which we have two types. You have a fixed antagonist protocol, and then you have a flexible antagonist protocol. Now, when we get to each one, you would know why they bear the names they do. Now, the single dose protocol, that's the French protocol. Basically, what happens in this protocol is that you give a single dose antagonist. Most often we use cetrorelix. About 3 milligrams of cetrorelix is administered on day 6 or 7 of stimulation. So what it means is prior cycle, no business with that. Index IVF cycle, you start your stimulation day 1, day 2, day 3, and then when you get to day 6 or day 7, you check your estradiol levels. Once they are more than 200 picograms per mil, you administer your single dose cetrorelix. Now, after that administration, the expectation is that your LH suppression would happen within 4 to 5 days of administration. And that day usually would coincide to a large extent with the day of trigger, plus or minus 2 days. Now, trigger is given if the criteria is met, and then, of course, you go ahead and do your retrieval transfers and all that. Now, if you administer your GnRH antagonist on day 6 or 7, and by the 4th, 5th day after administration, your follicles haven't met the size adequate or appropriate for retrieval of a trigger, you will continue to give a daily dose of the cetrorelix until the criteria is met. So you are tracking your follicles, checking on the sizes. Day 4, 5 after your cetrorelix single dose, you haven't achieved 1.6 to 1.8 millimeters of your follicular size. You will start administering daily doses of your cetrorelix until you get to the size appropriate for trigger. Now, that's an oxymoron because, of course, it's called single dose, but then we are throwing in some daily dosing after that. But that's the shortfall of the single dose antagonist protocol, right? So in saving money, sometimes you end up spending more money. And we know that with this, you are giving lower doses of gonadotrophins because ultimately you wouldn't need to give as much gonadotrophins as you would have if you were giving a longer period of administration of the antagonist. So you have a shorter duration of treatment, you have better compliance, you have a cheaper protocol, and ultimately you have better client satisfaction. But of course, remember that if you don't meet your criteria, you may have to give 2 or 3 more days of your cetrorelix for the achievement of your downregulation. Now, the multi-dose or multiple dose GnRH antagonist protocol, that's the Lübeck one. The gonadotrophins in this case, that's your normal FSH, HMG, whichever one you're administering, starts on day 2 or 3 of the cycle, just like we always do. And then you continue as we do all the way till your follicles get to the right size. And then you administer your gonadotrophins. So listen carefully. You are giving your gonadotrophins, you are monitoring your follicles, they get to the size, and then your gonadotrophin antagonist comes in one way or the other. So let's talk about the fixed type of the antagonist multi-dose protocol. Please tell me if I'm deviating, if I'm confused. Okay. So for the fixed one, you administer your cetrorelix on day 6 of the stimulation, irrespective of your follicular size. So you are stimulating with your FSH or whatever. You don't really care what size of the follicle you have achieved on day 6. You just give your 0.25 milligrams of your cetrorelix. Okay. But for the flexible type, you administer the 0.25 milligrams daily from a follicular size of 14 millimeters. So you're giving your gonadotrophins, you're tracking your follicles, you achieve a follicular size or mean follicular diameter of 14 millimeters. Then you give the dose 0.25 of your cetrorelix on the day you find your follicle at 1.4 centimeters or 14 millimeters, and then continue until the day of trigger. So 1.4 centimeters, you start your cetrorelix, give your cetrorelix till you trigger, you stop your cetrorelix. Now, I'm sure you can see from this that this is just based on people trying out different things, trying to achieve various things, because ultimately you may not have saved so much money on this, and you may not have achieved the kind of follicular recruitment you want from the multi-dose protocol of the antagonist. So I'll just go to the schema. This might help us appreciate it better. So for the antagonist protocols, your GnRH analogs, or antagonists, sorry, are administered till HCG trigger when the lead follicle is more than 14 millimeters. That's for the flexible one we just spoke about, or as a single dose on the 6th day of stimulation. Okay, so what it means is that your gonadotrophin start on day 2. We are stimulating our patient. We get to 1.4 centimeters. You give your shots and continue till trigger for the flexible, or you don't care what size of follicle you get on day 6. You administer your cetrorelix on day 6, and that's it for that cycle. And with these administration protocols, you will still achieve your downregulation as you require. And remember that the whole aim of the downregulation is to prevent your early surge. So you continue as you will for other cycles, trigger when the follicle is ripe enough, retrieve 35 to 37 hours after, transfer day 4, day 5, depending on what you get after incubation. Now, finally, we have a combined agonist and antagonist protocol. And in this protocol, you give your GnRH agonist. We are now back to our agonist, usually buserelin, at a dose of 0.5 milligram daily from the first day of the menstrual cycle for 3 days, and then you halt. You start your gonadotrophins on day 2 or day 3, and then your cetrorelix, which is your antagonist, now comes in at size 14 as per the flexible protocol we spoke about. You now continue that administration till your follicular size gets to the optimum for trigger, retrieve, fertilize, transfer. And so this is just a combination of the agonist and antagonist protocol. And it seems to be catching up with a lot of people now, because it seems to be getting you some good numbers when it comes to the follicles and some good outcomes when it comes to take-home pregnancy rate. So this is just an image of what we just spoke about. Day 2 to day 4 with your agonist, you stimulate your patient 1.4 centimeters for your follicle, start your antagonist, trigger when you get to 1.8, retrieve after 35 to 36 hours, fertilize, transfer after 4 to 5 days. Same schema after trigger, but before trigger, things tend to change a little bit. So this is just a comparison of the long agonist and antagonist protocols. We can see that, okay, something is missing on this slide. So this is the cycle where you have the longer treatment at the bottom. Where it ends is the cycle prior to the IVF cycle. So because you're giving your agonist in that, you have a flare effect, and it gives you a longer treatment. When you're doing your antagonist protocol, there's no flare effect. You're not giving anything. So obviously, you're not going to have a flare effect. There's no hormonal withdrawal because you're not giving anything at that point. Cycle starts. You can integrate your antagonist into an ongoing cycle already. And then your agonist, on the other hand, would help you exclude pregnancy because you've started your GnRH agonist way before the cycle starts. Gonadotrophin administration, as for both of them, and then antagonist comes in sometime during the gonadotrophin administration. And then, of course, your OHSS is prevented because you're using your antagonist, and you use less gonadotrophins for your antagonist cycle compared to the agonist cycle. So this is just a comparison of both agonist and antagonist in the pre-cycle and the index IVF cycle. Please, I hope I'm not confused people. Yeah, okay. All right. So finally, or almost finally, this topic wasn't very easy, but yes. So we have treatment strategies for patients based on special needs. So we have patients who have pretty high AMH levels, patients who have pretty low AMH levels. But what this slide tends to, excuse me, sorry, what this slide is supposed to do for us is to help us understand which agonist versus antagonist is best when your AMH levels are at a certain point. So if you have patients with unexpected high response, really high AMH levels, you are better off using your GnRH antagonists and starting with a low dose of FSH, about 150 international units. Now, with an expected normal response, those are those who have a normal AMH, depending on which range you're using, between 1 and 3 or 1 to 2.7. You are better off using a GnRH agonist. So for normal responders, you're better off using a GnRH agonist and jacking up your dose of FSH to about 225, a vial and a half. That may give you a better response. Now, if you expect a poor response from those who have really low AMH levels, you may still want to use your antagonist. Remember, we spoke about the fact that poor responders do better with the antagonist. And of course, you're increasing your FSH levels all the way to about 300 international units. So your AMH levels alone can actually give you an idea of how much of the GnRH, of the gonadotrophins to administer, and which type of GnRH analog, to use for such patients. And that's very important. This is just for an IVF denied cycle. So we've just said the same thing on both sides. Finally, so there is this combination protocol where you use a GnRH agonist and antagonist protocol. I think we spoke about that earlier. There are various modifications of that, but this is just another type of the GnRH agonist antagonist protocol. So we just go through one or two research papers which have spoken about the comparisons of both long protocol and short protocols. And I think the conclusions are very important, okay? For this paper, which was published in 2012 by DiPaolo et al., it compared clinical characteristics of the GnRH agonists and antagonists. And their conclusion was that protocols with GnRH antagonists are effective in preventing the premature rise of LH and induce a shorter and more cost-effective ovarian stimulation compared to the long protocol. Okay. Now, Yang et al., in their systemic review and meta-analysis in 2021, concluded that the best protocol for IVF is the outcome of the meta-analysis was that live birth rates, clinical pregnancy rates, and implantation rates were significantly higher in the long agonist protocol compared to the antagonist protocol. Of course, OHSS was significantly less in the GnRH antagonist protocol, which you know already. And then Oviedo et al. In 2023. So I tried as much as possible to just throw in very recent research, okay? And they basically talked about the stop GnRH agonist, GnRH antagonist protocol, which we spoke about just before, a couple of slides prior to this, okay? So this protocol, they concluded, protects from severe OHSS and maintains the option to substitute HCG with an agonist for the final maturation in patients at risk of OHSS. So with this protocol, where you combine both the agonist and antagonist, you get the opportunity to use your agonist for the final maturation rather than HCG, which significantly reduces your risk of ovarian hyperstimulation. And then finally, this study in 2013 just compared the depot, that's a single dose, just like Zoladex, what we use, compared to multiple doses of the GnRH. And the conclusion was that there was no evidence of a significant difference between a depot and a daily GnRH agonist protocol in downregulating in IVF cycles. So the take home from this paper is that giving a single dose of Zoladex is comparable to giving a multi-dose of another GnRH agonist if you are taking a patient through the long protocol. So in conclusion, finally, we know that infertility is still a major healthcare, social, and public health challenge globally, and in Africa especially. In Africa, when you have many babies or many children, you are considered to be wealthy. When you don't have children, there's stigma against you, and the women are the bearers of the most stigma when it comes to this. But we can see that men are the major contributors when it comes to infertility. Of course, the advent of ARTs, especially IVF, remains invaluable in addressing this major healthcare challenge. Access to ART services remain challenging in our society due to cost and accessibility. And then for the crux of our presentation today, the analogs are integral in the success of IVF cycles, with most protocols employing these agents in pituitary downregulation. So improved follicular recruitment, oocyte numbers, oocyte quality, embryo quality, pregnancy rates, and live birth rates are dependent on optimum downregulation with GnRH analogs. So you choose which GnRH analog, you choose which GnRH protocol you want to use, and of course, ultimately, you're trying to get more live births, but with as little complication as possible. Thank you very much, ladies and gentlemen.
Thank you very much, Dr. Chike. This presentation was very intense, and it shows that it's the last presenter. So, Dr. Paddy says they've given you all their time. So, yes. So now is the time for questions, and we would invite the speakers and our chairman to join us on the stage. So, Dr. Hiaji and our speakers. Okay. Okay. So earlier on, I introduced our chairman for this event, and he wasn't around to give his response. So I'll give it to him so that he leads the discussion. So we'll be having questions and answers. So if you have any question, you raise your hand, I'll come to you and you ask your question. So let me give it to Dr. Hiaji to give his response.
Good evening, colleagues, FESOC members, and other affiliates. What did she say, so I know what response to give her? It is my pleasure to have all of you here this evening for this Gynae, what's it called again? Gynae Summit. Yeah. I'm very grateful to the speakers because they were all called at short notice. Some people as short as 3 days, when other people who had the opportunity had to turn it down because of ill health or travel. So I'm very grateful that they took it up. And I think you'd all agree that they did justice to the topics and even more. I know Zoladex is an agonist, but there's been a lot of antagonists this evening. And it's because with FESOC, we always capture the opportunity to deal with as much as possible on our terrain. Being an old friend, I know wouldn't mind that even though we were just to talk mainly on Zoladex, we had to take the advantage of the opportunity to discuss the other things to do with the other protocols with IVF. Now, we'll leave the floor open for questions. There were 3 topics. One was the use of GnRH analogs in the management of fibroids by the first presenter, Dr. Michael Ntumi, and then in the management of endometriosis by Dr. Paddy Aite, and then finally in IVF by Dr. Chike Onuzo. So the floor is open now for any questions to them.
There's a hand.
Okay, thank you very much to our presenters. So my first question is to Dr. and to me. When you were presenting, you mentioned that one drawback of using the um, GnRH agonist in patients with fibroids is that the small ones may shrink so much you can't pick them up during surgery, and then you end up with like early recurrence post surgery. So then, how do we strike a balance in using it, like our patients benefiting from its use pre-op, but then to balancing it so that we don't end up having the fibroids disappear on us only for them to pop up a few months after surgery? And then to Dr. Chike, from the presentation and from the layman's perspective, it looks like the ultra shots, you have fewer shots, it's for a shorter duration, you save more money. So why are we not routinely doing more ultra short and short, but it's like the long is rather the norm, and then the ultra short and short are more of like the not the norm? Thank you.
All right, thank you very much for that interesting question. All right, there's no straightforward answer to that. But remember what I said from the beginning, you need to really evaluate your patient and decide what is the best form of treatment. So when the patient comes with complaint, remember most patients, more than 50% of your fibroid patients are asymptomatic. So if they come and you're small, you don't need to treat unless they have symptoms. So for those who are symptomatic, what is a major symptom? If it's a bulk symptom, then clearly these are big fibroids, or there are so multiple, you need to work on it. If it is abnormal uterine bleeding, where is the location? Remember we mentioned that you need to evaluate the endometrial cavity. So if you have the FIGO type 0, 1, then possibly do hysteroscopic resection of those. That will solve your problem and leave the rest of the fibroids for the woman to go and conceive. But if you think that you need to really give Zoladex, there is an education to the woman. We were going to give you this medication, it would manage you temporarily to stop your symptoms. But then once we stop, they are likely to come back. If you are going to do the surgery, it's possible that you may have recurrence. So use the period soon after the surgery. After 4-6 months after the surgery, uterus is well healed, go and get pregnant. Otherwise, you are going to have a recurrence of that. So it depends on the individual, what you discussed here, but there's no short or direct answer to that. Thank you.
To add on to what Dr. Ntumi said, even when you don't use Zoladex and you do surgery to remove fibroids, if they're very small, you wouldn't see them. And they can still grow later. That is why it is always imperative that you let your patients know that 6 months after the surgery, they should aggressively try to get pregnant. Otherwise, whether the fibroids were not seen because of pre-surgical use of Zoladex, or that they were just too small at the time you did your myomectomy, there is still an opportunity for them to grow if you don't do anything. I think the dilemma comes if the person is not ready to get pregnant after your myomectomy, either because they don't have a husband or for some other reason. So what do you do then? We'll keep thinking.
I think I'll just add a little more to what Dr. Hedgie has said. I think that should also affect or should also help us determine who actually needs a myomectomy. If you find or incidentally find a fibroid in a patient you're assessing for something else and she's not ready to have kids, I think you should really consider whether she needs that myomectomy or not, especially when it's just for cosmetic reasons. Her tummy looks big or something else. You may want to consider probably shrinking the fibroids and taking your time to do a surgery, because of course the risk of adhesions and all that will definitely affect fertility. So to my question, sorry. So what I'll say about the ultra short protocol is that there's a higher risk of cancellation for those protocols, and that's because you may not end up with the kind of down regulation you actually aim to achieve with an ultra short protocol. ultimately, you may have an LH surge you didn't anticipate at the beginning of the cycle, just because you're giving your GnRH analog for such a short period of time, within 2 or 3 days, and it may actually fail you. So higher risk of cancelled cycles. And of course, the yield tends to be less when you do an ultra short GnRH agonist or agonist protocol. So you might not get as many follicles as you desire from those protocols compared to a longer protocol. So people would lean towards a long protocol or just a short protocol rather than the ultra short, because in this part of the world, of course, we are trying to recruit as many follicles as possible for our IVF cycle, just to give us the opportunity to have our extra embryos for cryopreservation and then future or further transfers in other cycles. Availability of the multi-dose GnRH analogs is another thing another factor which may determine whether we do our long protocols or our ultra short protocols. So those are the 3 points I have. I don't know if Dr. Hedge wants to add something to that, or Dr. Paddy. Okay.
Yes, I think the availability of all these various protocols, it's important because we are reaching the era where there should be individualized care, even individualized selection of protocols. So one protocol does not fit everybody or every situation. I must say, I had a question for him where the antagonist protocol seems patient-friendly, time constraints and all that. But would you transfer immediately after you harvest your eggs in an antagonist protocol? No, we are, this is a discussion. We are doing presentations. Yes, the antagonist protocol is beautiful. Within 2 weeks, you finished from the start of the period, but you can't transfer because the antagonist protocol, the endometrium unsuitable for implantation. So you have to freeze them. So it's good for when you want to do PGT, because you need time for the genetics to be done. It's good for when you're doing fertility preservation, because you're not ready yet. It's good for when you preparing for oncofertility, where you need to freeze before some cancer treatment. So there are specific instances that you would find them, but it's good to have all the protocols and use them appropriately. That way you have a good result overall, because you're selecting according to the requirements of that particular patient. So the ultrasound has its place, but it doesn't fit everybody. So it was too short a period to discuss all the details of the various protocols. But I think on an occasion, we will take that as a CBD topic and just go through them all. He had to rush through all of them and didn't have time to explain everyone. And I could see people were getting rather confused with all the jargons that were coming out. Yeah, but it's good. It's a very good attempt to show that there are different protocols out there now. A long time ago, it was just one main one, but things are changing, and I believe in the next 6 months there would be another protocol. Yeah, there's a lot of research going on. More questions, please.
Yeah. Okay, good evening. Please, my question goes to Dr. Ntumi and Dr. Paddy. Dr. Ntumi, if a client comes and she there's an option to use the GnRH agonist for fibroid reduction, and say the patient wants to avoid surgery but wants to get pregnant, is there a rule for giving the Zoladex to reduce the fibroid size to encourage her to get pregnant? If yes, then okay, please can you explain that? And then Dr. Paddy, I saw I've seen quite a number of people who are paying should I say who are pethidine or let's say opioid addicts with endometriosis. After the surgery, and then you give the analogs for, you said it reduces the recurrence for about 2 years. It encourages reduces the recurrence for about 2 years. So if let's say after 2 years they come back with resurgence of symptoms, do you put them back on the analogs or we move to other options of treatments? Thank you.
All right, thank you very much for your question. Yes, ordinarily I wouldn't recommend that kind of treatment. The reason is that once you give Zoladex, first of all, you must decide whether the person needs treatment or not. Okay, if she's symptomatic, either having menstrual bleeding or recurrent miscarriage, it's clear there's a problem with the endometrial cavity. So fertility-wise may not be, unless you have the one that is just bulk with a normal endometrial lining, which is not too common, except the subserosal one. So once you give the Zoladex, remember that this is going to suppress ovulation. So at the time you are giving it, you will not achieve pregnancy. And once you stop, data is that within 2 to 3 months, there is rapid resumption of gonadotropins, and then things go back to normal. So if you have a patient who wants to conceive, just give me the Zoladex to suppress symptoms will not be the case. So rather, you want to suppress symptoms and then go into a definitive treatment to correct an underlying problem, and then you can encourage pregnancy. That's what I'll say about that.
Thank you for your question. And to add a little bit to what he said, the fibroid, you have to determine what the fibroid is doing to the client. If it's affecting fertility, you're shrinking it a little bit. By the time you take it off, it's still going to affect fertility. You are better off taking off that fibroid. If it's not affecting fertility, then it's not preventing her from getting pregnant. So the fibroid is not the issue. We should be looking for some other reason why she's not getting pregnant, and let's work on that instead so that she can get pregnant. It's not every fibroid you must remove, or just because the fibroid is there, it must come out. We say don't poke the devil's eye. If it's lying there quietly, leave it alone. But if it is submucous, get a hysteroscopic resection done. It can be done as a day case. Client goes home, and then you give her a month. Like after a month cycle, the endometrium usually you come back to normal. By second month, you're trying to get her pregnant before any other fibroid starts recognizing the fact that there's a free space there, and let me start moving in that direction. So it's available, and you should be able to do that for a client. The question you asked was about what happens afterwards. The challenge has been that a patient comes with endometriosis, and either there's no treatment, and then they get analgesics, and then get stuck on opioid, or treatment is given, and then after they suppress for 3 months, and then they stop. But there are various things that can be done for the client. But to specifically answer your question, there are treatments that you can give after you've decided that you don't wish to continue with, like, say a Zoladex treatment. So you give for 6 months, or now you can actually give for a year. After a year, we know that, okay, for the next maybe a year or so, should be fine. But during that period, we can add, there are other things that we can use to suppress the estrogen level. Letrozole, which we mentioned earlier, an aromatase inhibitor, it effectively blocks estrogen production. So if you give letrozole continuously, 2.5 milligrams on a daily basis, it will prevent the estrogen levels from rising even after your Zoladex, wears off. That result is going to ensure that she's going to remain in a relatively hypoestrogenic state, and then it will not rise again. The contraceptive pill also allows you to have a lower estrogen level than you would have had under normal circumstances without it. If you combine letrozole and a contraceptive pill, you're actually getting a far better block. And that also prevents you from getting the cysts that occur when you use letrozole on a continuous basis, because the way it works, it causes follicular development. So if you're able to block with a pill, the other side with a pill, you don't get cysts on it. There's something that is called ECGC, long name. It is derived from it's a green tea extract. It also suppresses, it's a very effective anti-inflammatory, but it also suppresses estrogen production. So it's beneficial to clients in that case. There's actually a protocol that combines ECGC with D-carotenosytol, with vitamin B6. And if you combine all those together, it has been shown to reduce the rate of growth or recurrence of those conditions. And it doesn't have as severe a suppressive effect as Zoladex would have. So the trick is start with Zoladex and then maintain with something else.
Okay, thank you, Doc. There are some questions online, so I'd like to read the first one so that you are. So the first one says, thank you for the brilliant presentation, Dr. Ntumi. Seeing the risk of shrinking, the very tiny nodules. Okay, let me take it again. Seeing the risk of shrinking the very tiny nodules following the GNRA preoperative therapy, what would be your experimental and evidence-based advice regarding its use in younger women, say below 30 years, who naturally would stand a relatively higher reoccurrence risk?
So I think this question has been asked, so we've answered it properly. So, but the take home is this: don't treat because she has fibroids. Most fibroids don't need treatment. So if she's young, she's 30, it's not symptomatic, leave her alone. Okay, but this question was asked. I think the first question I had to answer. That's that.
Okay, the second one is that what would you say regarding the use of TVS guided endometrioma drainage plus post drainage cycles of GNARH?
Okay, so I think that is for IVF. Okay, for endometriosis, you have endometriomas. What the concept of drainage, transvaginal drainage, is for endometriosis. It's not a straightforward answer. Some people would go for that because it's very straightforward, it's easy to do, but there's a risk of seeding the tract with your endometrial tissue. So much as it is simpler and it's easy to do, if you be using ovum retrieval and drainage seeds from IVF theaters, can easily do that. That's easier for you, and the patient can have treatment later. But the danger is that you run a risk of seeding the tract with the endometrial tissue. So you have to discuss that and decide what to do for that patient. But I don't know whether I have anything to add to that.
It gives an immediate benefit. The challenge is that it will recur, and that's a major problem. And the other, usually when you have a significant endometrioma, like an endometrioma, you would want to do surgery. The challenge with surgery is that you lose good ovarian tissue. So that means you lose the oocytes that you need to be able to get pregnant, which was your objective in the first place. If you are going to do an IVF cycle immediately, then yes, there's some benefit to reduce the inflammatory component that is there and would allow you to do your cycle right now. If you are going to do it with the intention of the fact that it's a do and wait, it will not have that much effect, because just give it if by the next cycle, the woman she bleeds, it will start reaccumulating, all over again. And in a few months' time, it will be, large like that again.
So I have a question, Dr. Please, am I allowed to ask questions? Yeah, I'm allowed to. So what do you then do when you have a patient with an endometrioma which is symptomatic, no reproductive wishes immediately, but you are also wary of these, follow-throughs with the surgeries and the transvaginal drainage? Because the dilemma we usually have is you drain this endometrioma. Some people have suggested injecting sclerosant or whatever just to, get the walls shrunken and all that. But the endometrioma wall is really thick. So you're just puncturing the wall, getting out. And I have actually seen an endometrium reaccumulate real time during the drainage. I think we went into a vessel and it just filled up again. So what would you then recommend to a patient who you are wary of surgery? Because, of course, you're worried about the future fertility preservation, and then the patient is symptomatic. Because, Zoladex will probably not do much.
If the patient is symptomatic, has got an endometrioma, let's say 5 centimeter mass or something of that sort, and she doesn't have an immediate need for surgery, her immediate need is pain. And the solution for that is surgery. Laparoscopic surgery, not open surgery. Laparoscopic surgery. because it has been shown to be better, less scarifications, and the quicker recovery time. And in that process, you can actually see, because of the magnification, you can see the lesions all over the place. Unfortunately, it has to be done by somebody who is quite skilled. Laparoscopic surgery for any surgery for endometriosis is a horrible surgery. But some people are really good at it. I've seen some brilliant dissections, and you're pretty impressed. And all I think about is, I'm never sure I'll get that skilled before I die. But if you get a good person, that kind of person who is not ready for immediate fertility treatment, you just have to laparoscopic surgery, remove the endometrioma, remove whatever lesions are there, suppress whatever is there over the next few months or years, and then hopefully counsel them that, you know something, as soon as we get off this, we should be trying to get pregnant as quickly as possible. If there's availability of harvesting eggs, freezing embryos, or freezing eggs, I think advantage should be taken of it, because endometriosis is a progressive disease. It's going to get worse. It's going to come back. I'm trying to get that pigtail catheter thing to try the sclerotherapy and see if we can get that to work. I think it's an easier way of managing the thing, especially for those who can't want surgery immediately.
I think endometriosis can be considered a malignant disease because of how progressive it is throughout your reproductive lifetime. I was in a conference when we had a presentation by a nurse who had endometriosis herself, telling us about what she'd been through, and she was preparing for her 15th surgery after the conference. And so we all know also how very, very therapeutic pregnancy is to endometriosis. And so I think it's our duty to encourage women who come with endometriosis to start thinking about getting pregnant. If they're not ready, they should try and freeze their eggs, because the devastating thing is, after you've gone through all that pain and you finally decide that you want to have kids, your ovarian reserve is just too low. Even at that stage, you can encourage them to have oocyte donation, because when they do get pregnant, that endometriosis pain goes and they still have a child anyway. So it's a progressive disease that we need to help to intercept it at some point in their reproductive cycle. Otherwise, they end up with pain, and childless at the end of the day. Thank you.
No, I was just going to add that. So from the question you had, the current recommendation is that because the medications will not work on the endometrioma, if they are symptomatic, yes, you can start the medication, including Zoladex. That will suppress the other active endometriotic deposit. Then you can go follow up with surgery, preferably laparoscopic, as Dr. Paddy said. After the surgery, then you need to go with other suppressants, typically combined pills or high-dose progestins, if the person cannot be on Zoladex or generally for a very long time. But in the meantime, you need to counsel them. You need to counsel them about conception, like Dr. Hanaji said. If they are ready, why not? Go for it. If they are not, then stimulate them, have their eggs frozen, so that at the right time when they come back, you can have it done. Because clearly it's progressive disease. They are going to come back. They're going to have multiple surgeries. Some of them, we are getting a lot of them with Catamenia syndrome now, and don't just the pelvic pain, and they need to have children. So what do? We need to get on and then encourage fertility preservation, so that at the right time when they are ready, the eggs are there to be used.
Okay, so there's an interesting question here. It says, hello, Dr. Paddy. Please touch on a bit of how men get endometriosis.
Okay,
That's why I said it's interesting.
Okay, so I'll give you a couple of, okay, yes. Gentleman has a lower abdominal mass, tender. He goes to the hospital, he's examined, they can't find the cause. They do evaluations, and they eventually decide that let's do laparotomy. So they did laparotomy and opened it and discovered that they did a histology, and it was endometrial tissue with all the markers that show that it is endometrial tissue in a man. And that is no, he wasn't. It's a man. XY man. So they ran, and there's actually a case series. I didn't put it on the slide because I thought it was going a bit out of scope. But there is a list of cases that people have actually encountered, that they've listed cases of men who have been found to have endometriosis. What was common amongst almost all of them are that they had conditions that caused them to have higher levels of estrogen. Either they were people who had prostate cancer and were given medication that was suppressing testosterone and raising estrogen levels, or some particular guy that was rather obese and was naturally producing excessive amounts of estrogen. And then there were a few cases of people who had repeated hernia surgeries, because somehow chronic inflammation in that particular portion resulted in them having endometriosis. And when we talk about the possible causes of endometriosis or the pathway by which it comes, well, up there has been retrograde menstruation, and these guys don't have menses. And so it starts asking us questions as to maybe some of the other parameters matter more than this one. But men have been found to have endometriosis if they have high levels of estrogen. And the specific examples that were noted were people who are on treatment for prostate cancer or had high level of estrogen due to high BMI. So if your BMI is high, be careful.
Yeah, I would want to find out from Dr. Chike about the IVF protocols. I mean, talking about endometriosis, whether, I've seen one of the protocol, ultra long. I heard ultra short, long or short, ultra short, ultra long. Can you?
I don't
in
think
the
I
context
mentioned,
of.
No, I didn't mention ultra long. It was just a long protocol.
Yes, but in the context of endometriosis for fertility, yeah, I don't know if you.
Yes, I think that, just like the question that came about the fibroids, treating with GnRH analogs, and then pregnancy. If you have a patient with severe endometriosis, you're managing with either a combination of surgery and pharmacotherapy or just pharmacotherapy with Zoladex, you can actually dovetail the last cycle of your Zoladex administration into an IVF cycle. So you give your Zoladex, you suppress the endometriosis over a period of time. Your last shot of endometriosis then your last shot of Zoladex then becomes your agonist for the long cycle. I don't know if that makes sense. And then you just dovetail into your IVF cycle. So I think that makes sense. Of course, the other question is, if you have your endometriomas, do you go ahead and stimulate, or do you deal with that first before you go ahead to stimulate? I guess that would depend on how big your endometrioma is, if it's bilateral, if it is symptomatic, and most people would discourage stimulation with an endometrioma in situ. You may want to deal with that first before going ahead with your stimulation. But there is definitely a place for treating your endometriosis and then just continuing or dovetailing into an IVF cycle. That's what I think.
Yes. Hello. Yeah, what is said is exactly true. You give your Zoladex monthly for 3 months, and by that time it should become amenorrheic. So then you have your down regulation already, and then you start your stimulation with your gonadotropins. Harvest your oocytes. By then, all the inflammation is suppressed. all the active endometriosis is suppressed. You check your markers, CA1 to 5 will be very low, and then you can go ahead and do your transfer with a good result. Yeah. When it comes with the endometriomas, I'm not a good laparoscopic surgeon. I decide I won't go far because my plate is already full. So if there's a huge endometrioma, I do laparoscopic surgery anyway, sapingectomies for ectopics and all the rest. But I just don't want to go into endometriotic surgery. It can be very, very daunting with all the adhesions and all that. But you can open up the endometrioma and wash it nicely, give you Zoladex, and then your next cycle you can stimulate, also with good results. So it depends on the extent. There are many ways that you can handle these situations. So it comes in pretty handy. So for that, they will be better off with a long cycle or the agonist cycle to get your suppression, and then you do your stimulation rather than an antagonist. That's where the individualized care comes in here.
And then, of course, you can drain your endometrioma in the index cycle of the IVF. I mean, it might be messy because the patient might be menstruating at the beginning of the cycle, but you can actually drain the endometrioma transvaginally with your what's it called, your retrieval needle or whatever, and then start your stimulation. In that case, you might not get your endometrioma as huge as it was prior to your stimulation, and you might not get it become bigger with your stimulation in that index cycle. So that's another option for dealing with it. Yeah.
So we have a last question, and then we can end the session.
Yeah, hello. Please, my question goes to Dr. Chiki. In the presentation, with regards to the long agonist protocol, I think goserelin seemed to have a role to play only when we are using the day 21. I want to know whether it has any room. There's any room for its use in the short protocols that were mentioned. And then two, there used to be this notion that even though donor protocols were not mentioned, like in doing donor recipient protocols, that women in advanced ages don't respond well with the depot or the goserelins. I want to know whether, in line with current research, whether there is any research debunking that. Thank you.
Okay, thank you. So I'll start with the second question. So theoretically, you would want to lean towards the antagonist protocol for older women, based on very low AMH levels and based on the data that shows that the response is better for older women who are, trying to achieve autologous IVF cycle pregnancies. So yes, the papers say that older patients don't do too well on the depot versus giving them the daily dose administration. I've seen 2 papers stating that, but theoretically, you may want to lean more towards the antagonist protocol. But just like Dr. Hiaji said, you need to have adequate cryopreservation, or freezing, services in your IVF center to carry through with your antagonist cycle. And remember that these women are already hypoestrogenic. So the endometrium is even going to be worse when it comes to the antagonist protocol. You might get further thinning of the endometrium for them. So it means that transferring in the index cycle might be pretty difficult. Even if you administer your exogenous estrogens, you might not get the kind of endometrial thickness you require for transfer. So the antagonist protocol will probably be a better option for the older woman compared to the agonist protocol. And then the other question was about the Zoladex and then the short cycles. Yes, I think Zoladex has been used for short cycles. I don't know about the ultra short cycle, but you can use Zoladex. You can use goserelin. The only issue I don't know about is whether the multi-dose administration or administratable doses are available in Ghana, but you can use it in your short cycle. The ultra short, I can't really speak to that. I'm sorry. Okay, I don't know if you have.
Sadly, we don't have all the medications that you can use for all those various cycles here. The pharmaceutical industry is a huge industry, and they provide to areas they want to provide to. We've had difficulties in the past, but AstraZeneca has been very good in the last few years when they realized the uptake of the Zoladex. They've tried to make sure it's available most of the time. But your question about the buserelin, it's not only with the D21, you can use it as a long cycle starting with the period as well. And you can also use it as your agonist trigger for the antagonist protocol. So they play various roles in many protocols, but you have to, again, be very selective of who you use it for. And availability also becomes the issue. We shall address that in another sitting.
There's a last question, and then we end the session.
Good evening. So I wanted to find out, at which point in time do you decide that someone who has endometriosis, or more specifically adenomyosis, will benefit from doing a surrogacy rather than a cell cycle? Because let's say, assuming you've given your Zoladex and in your 3 months, you've done, and you're still not getting as much, is there a way you see a patient with adenomyosis and say, okay, no, this person, I think that we should just go straight away and look at surrogacy?
Adenomyosis is one of the most horrible conditions that anybody can have. So for quite a number, if your patient, for example, is always producing a brownish discharge, your adenomyotic patient, she tells you that she's always having a brownish discharge. If you did a hysteroscopy, you would see that there are small, small holes that blood is coming out of. It's not a lot of blood, but they just keep, just like that. If you press against it, you see the blood coming out of it. She's always going to have a bad environment inside there to put a baby in. It doesn't matter what you do. So if you've done your scans, you've seen adenomyosis, you've examined her, and she tells you that she keeps having those brownish discharges, it's not going to work. For that client, it's not going to work. If you do your scan and you see that there's adenomyosis on all walls of your uterus, like in front and behind, and it's close to the lining, most likely it's not going to work. The surgery to do the adenomyosis is difficult. The last one I did took me 4 hours. Patient was paying free for a couple of years, but I don't want to do another one again. It's difficult, and it doesn't guarantee that she'll get pregnant, because by the time you finish, you have effectively dissected the endometrium off the myometrium. And even though viability is maintained, can it carry a pregnancy? It's a bit of a problem. So if she has a large bulky uterus with adenomyosis involving all over the walls, it is unlikely that she's going to implant. If she has a brownish discharge that comes consistently, it's unlikely that she's going to implant. If you've tried to suppress it by using Zoladex and you have not been able to achieve much of a result, it's unlikely she's going to implant. I'm sure maybe Dr. Haji will have a few more to add. But once you see those things, you know that counsel for surrogacy, it will help.
It's always a very difficult one, especially there are people who, despite everything, they want to tell you that they want to carry their own baby. After all the scientific explanation, down to earth experience, you tell them and all that, they want to carry their own baby. So there are times that you have to allow people to have closure. Otherwise, they wouldn't accept it. So when you do your best and they believe you, they would accept the surrogacy. But if they don't believe you, they may ask you to try. On that occasion, what do? You try. If it works, it will give you hope for the next person who will come with the same situation. But it's always important that you give them as much scientific explanation. They look up to you to try and convince them. And after you do all that, give them time to come back for you to have further discussions, particularly if they've had some surgery before. If they've never, and they were told somewhere else that it's a fibroid, then they wouldn't believe you, and they may go somewhere else where the person may not take a good look or assess properly and try to operate, and it becomes an open and close. Or if she's unfortunate, she might lose her uterus completely. Not that if she does surrogacy, the uterus is of much help anyway, but in our part of the world, you don't take a woman's uterus out just like that. So it's a very difficult one. A good question to end the session for us to keep thinking about solutions for that. I remember always trying to go into any conference topic, program that is discussing adenomyosis to see what new thing would come, because it's something that when you open up and you see it, you wish you had 40 fibroid nodules to remove rather than this 12-week size hard mass in front of you. You slice them off, you can't even stitch them because you will cut through the muscle wall. It's horrible. On this note, I'll hand over to our host.
Thank you very much. Yes. So thank you very much. I have learned a lot of things. I have lots of information today. And so from AstraZeneca, Zoladex is available. I heard Dr. Hiaji mentioning that availability, we've done very well. So it's available. There's no issue when it comes to availability. So it's available for all our patients. We have the 3.6 milligram and then the 10.8 milligram. 10.8 milligram is mostly indicated in prostate CAs. Yes. So I'd like to use this opportunity to thank our chairman for this August occasion. We really learned a lot from the speakers. I would like to thank Dr. Michael Ntumi, Dr. Paddy Ayete, and Dr. Chike Onuzo. You've done very well for us. We've really, really learned a lot. So without talking too much, tummies are rumbling and, so dinner will be served at the restaurant. So we'll use this exit and then there are coupons for us to use at dinner. So thank you very much. Yes.
Thank you. Sorry for twisting your arm, but I'm sure it was a good opportunity.
It looks like we are not hungry. Am I the only one who is hungry? Please, let's go. I beg you.
listening to us. So thank you so much, our online participants. And also thank you, CES, for our streaming service.